Chalo, hopefully the audio visuals are clear. Let me know in the chat box. Double target sign, it is not double hello. Great, chalo. Question number 16, if they ask you, the question states, beta, question number 16 is, a neonate was born, beta, who has been brought to the emergency with complaints of respiratory distress, and along with that there is cyanosis in the baby, beta, and this cyanosis improves whenever the child starts crying. Okay, this is very classical presentation, that the cyanosis of the baby is going to improve whenever the child starts crying. Matlab, whenever the child cries, the baby turns pink. Okay, and it worsens while the child is feeding, beta. Okay, a nasal endoscopy of this patient is usually done, beta, and it has been given below. Choose the most inappropriate statement, bache. Not the appropriate, they're asking you to choose the most inappropriate statement, beta. Okay, about this clinical condition. First, tell me what is the likely diagnosis of the case, even by the classical presentation of the child, beta, or even basically, beta, by the endoscopy. The diagnosis is very clear, and that is nothing else, a case of bilateral choanal atresia, beta. We know that the posterior nasal opening which is there, it is known as choana. If I talk about the posterior nasal opening, beta, when this posterior nasal opening is not formed, beta, when this posterior nasal opening is not formed, bache, that is called as a choanal atresia. So normally we know that this posterior nasal opening or choana should be formed, but in some conditions, beta, the posterior nasal opening is not formed in the baby. Okay, and there will be a septum called as the bucco-nasal septum, beta, and therefore the choana doesn't form. And this condition you are able to see when both the choanas are not formed, beta, is a classical diagnosis of bilateral choanal atresia. We know bilateral choanal atresia agar hai, so obviously the baby will not be able to breathe with the help of nose, beta. Why the baby is not able to breathe with the nose? Reason is, beta, you are able to see that the baby is actually going to have what? The baby is actually going to have a septum at the choana. So that's the reason the baby will not be able to breathe via nose. And we know, beta, the problem is what? Neonates are obligatory nasal breathers, beta. Neonates are obligatory nasal breathers. So that's the reason what is going to be done. Please remember, as neonates are obligatory nasal breathers, they don't have the ability to understand, beta, that if they are not able to breathe via nose, they can open their mouth and breathe. That's the reason this problem happens. Kya hoga? As the child is not having the ability to understand, beta, that it can open the mouth and breathe, isliye the child will actually have a severe respiratory distress, and due to that severe respiratory distress, the baby develops cyanosis, beta. But important to be remembered is, yaad rakhna, if the baby develops cyanosis, this is very classical presentation, that whenever the child starts crying, beta, the cyanosis improves basically. Why? Reason is, whenever the child will cry, beta, for crying the baby will open the mouth, and then some amount of air or oxygen will enter via the baby's mouth, beta, and that's the reason the baby's cyanosis is going to improve basically, or it will decrease. Whereas the cyanosis worsens whenever the baby is feeding, beta. Why the cyanosis will worsen while feeding? Reason, during feeding the baby's mouth will be closed, beta, and that's the reason the baby will not be even able to breathe via mouth, and that's the reason, beta, the cyanosis of the baby will worsen. That is very classical about choanal atresia. I've told you choanal atresia is associated with which syndrome? Let me know that in the chat box. Which congenital syndrome is commonly associated with choanal atresia? We know choanal atresia can also occur if the mother has taken a carbimazole drug or methimazole drug during pregnancy, beta. Carbimazole or methimazole, like antithyroid drugs, are known to cause either cutis aplasia or choanal atresia like teratogenic side effects, beta. That is important. Clear? Choanal atresia, this is the classical presentation. Here we know, beta, when the baby has choanal atresia, the first step in management is what? We have to insert a wide bore nipple in the baby's mouth, beta. Okay, this wide bore nipple that we insert in the baby's mouth is actually going to keep the baby's mouth open, and that is called as McGovern's technique, beta. So okay, so to make the baby breathe, basically, to make the baby breathe, we have to keep the baby's mouth open, and for that we have to insert this wide bore nipple in the baby's mouth, which will keep it open, beta. This is classically known as the McGovern's technique. Hopefully clear to all of you now. That is important. But if in case the wide bore nipple is not available, then I can also insert a oropharyngeal airway, beta, called as a Goodell's airway. I can even insert a oropharyngeal airway, bache, that is a Goodell's airway. This was a previous year question from August 2020 FMGE, that there was a classical case of choanal atresia, and they asked you what should be the next best step. The next best step should be nothing else but inserting oropharyngeal airway, beta, in the patient's mouth to keep it open. So if McGovern's technique is not an option, the second best answer is insertion of the oropharyngeal or the Goodell's airway, beta, which can be done. Very good. We know beta that this choanal atresia, as I've told you, it is very commonly associated with a condition known as charge syndrome beta. This choanal atresia is very commonly associated with a condition that is known as charge. Just a minute. It is commonly associated with the charge syndrome, which is going to have multiple other congenital anomalies beta. It is commonly associated with charge syndrome, which is going to have multiple other congenital anomalies also. Clear? Now, if they ask you, it is a case of choanal atresia, that's clear. They are asking you which among the following statement is inappropriate. Let's talk about one by one. Option A says beta, it occurs due to persistence of the bucco-nasal septum. Is it true? Yes beta, we know that the bucco-nasal septum between the buccal and the nasal cavity should disappear at birth, and that should lead to formation of the choana. But in case if this bucco-nasal septum is persistent, if it does not disappear, then the patient is going to have this problem of choanal atresia. That's true. Option B says recanalization surgery is done at birth. No beta. We know that the surgery for choanal atresia should not be done at birth immediately. It is usually done at 1 year of age beta. Okay, the surgery of choanal atresia is not done at birth. It is usually done by 1 year of age. Next, it is associated with charge syndrome beta. Yes, we know it is associated commonly with other group of anomalies called as charge syndrome. Option B says Goodell's airway insertion is the initial management. Yes, either McGovern's technique beta, that is wide bore nipple insertion, or a Goodell's airway insertion beta, that is the oropharyngeal airway insertion, will be the initial management, which will keep the baby's mouth open so that the baby is able to breathe. That's true. So the inappropriate statement beta or a false statement in this has to be the option B beta, that surgery is immediately done at birth. No, it is not immediately done at birth. Clear? Next is question number 17, which is very classical and sarkari question of PD and ENT. Here you are able to see a case beta where we have a 2-year-old child, which is, and this 2-year-old child is actually presenting to us beta with in the emergency. Yes? This 2-year-old child is coming to us in the emergency with complaints like fever and respiratory distress. Along with that, the baby is having drooling of saliva. The baby would have drooling of saliva over here beta. Reason is whenever the baby tries to swallow the saliva, as the patient's larynx and pharynx are inflamed, patient has a lot of pain while swallowing beta. Therefore, he does not even try to swallow the saliva, and the saliva keeps on drooling out from the mouth. And his mother told that he has been refusing the feeds since yesterday. Reason I've told you, as there is a painful swallowing beta, therefore the baby does not even take any feed. X-ray soft tissue neck beta, lateral view has been given. So X-ray soft tissue neck lateral view has been given Okay, what is seen on that X-ray soft tissue neck lateral view? And now they are asking what is the most probable or the possible diagnosis beta. So here you are able to see beta, this is the X-ray soft tissue neck lateral view. On the X-ray soft tissue neck lateral view, what is going to be seen? Bolo. What is seen on the X-ray soft tissue neck lateral view? कहाँ थंब दिख रहा है भाई तुम लोगों को? Where you are able to see a thumb sign? I am not able to see any thumb over here. I am not able to see any thumb over here. Thumb is basically like this whitish shadow na, which looks like a thumb. Here there is no whitish shadow which is looking like a thumb. So definitely you are able to see that there is widening of the prevertebral shadow. Can you see here the prevertebral shadow which is there? It is very wide beta. Okay, so I am able to see on the X-ray soft tissue neck lateral view that there is a widening of the prevertebral shadow which is seen. Okay, and whenever there is a widening of prevertebral shadow, that means we know beta there is collection of pus in the prevertebral spaces. Now which are the types of prevertebral spaces beta? One is a prevertebral space, second is a retropharyngeal space beta. So if there is widening of prevertebral shadow, it could be a case of prevertebral abscess or a retropharyngeal abscess. Now to differentiate whether it is prevertebral or retropharyngeal abscess, what we have to look at? We have to look at the cervical spine or the cervical vertebrae. Here I am able to see beta, the cervical spine or the cervical vertebrae absolutely looks normal beta. There is no damage of the cervical vertebrae. So here there is widening of the prevertebral shadow along with, okay, here there is widening of the prevertebral shadow beta along with the normal cervical spine. We know whenever there is a prevertebral shadow widening along with the normal cervical spine beta, that means the pus collection is not usually inside the prevertebral space beta. Then the pus collection is not actually inside the prevertebral space. The pus collection is usually inside the retropharyngeal space, right? The spaces of Gillette. We know behind the pharynx there is a space called as retropharyngeal space, okay, which is divided into two halves beta by a midline septum. And in that, definitely if there is collection of pus, that is called as the acute retropharyngeal abscess. And I hope all of you are quite aware that acute retropharyngeal abscess will have a very close presentation like acute epiglottitis beta. Hopefully clear. The same age group, 2 to 8 years of age, same presentation like drooling of saliva, fever, respiratory distress, hot potato voice. Okay, all these features are going to be same beta. So if the patient is having a very close differentiation with acute epiglottitis, but X-ray soft tissue neck lateral view does not show you any thumb sign, but rather it shows you widening of prevertebral shadow with normal cervical spine. My diagnosis has to be nothing else but option D beta, that it is a case of a retropharyngeal abscess. Now, why not acute epiglottitis? Because an X-ray soft tissue neck, it has to be a thumb sign which should be seen beta. That is the reason. Option B says prevertebral abscess. Yes, in prevertebral abscess, X-ray soft tissue neck surely shows you a widening of prevertebral shadow, but along with that, we are able to see a damaged cervical spine. Okay, so in prevertebral abscess, why it cannot be a diagnosis? Because in prevertebral abscess beta, we are going to have a damaged cervical spine. Here there is a tuberculosis of spine or pod spine beta, which damages the cervical spine, and then there is pus collection in the prevertebral space. So that's the reason beta, prevertebral abscess is not the choice. And second, prevertebral abscess does not show a presentation similar to acute epiglottitis. Next, parapharyngeal abscess. Parapharyngeal abscess is seen on the sides beta. So parapharyngeal abscess is a close differential for quinsy, that is a peritonsillar abscess. Quinsy and parapharyngeal abscess, both of them will have exactly the same type of presentation, which is, that is, in both the conditions, the patient will have high grade fever. Patient definitely may have better difficulty in swallowing, that is dysphagia. Patient may at times even have dyspnea beta. Okay. Patient definitely will have a lot of pain while swallowing, that is odinophagia. Patient may have locked jaw or trismus. These are common presentation. On examination also, if you see, in both the conditions, parapharyngeal abscess or quinsy, there will be a common presentation, that is tonsils are pushed medially and the uvula is pushed towards the opposite side. The only difference between a parapharyngeal abscess and a peritonsillar abscess, that is quinsy, is going to be what? Let me know in the chat box. What is the main difference between parapharyngeal abscess and quinsy beta? Let me know in the chat box. तो यहाँ पे देख सकते हो बेटा. Here, if you are able to see this picture, I hope all of you are quite aware. This is the classical thumb sign beta. Can you see? There is the thumb sign which is due to the swollen epiglottis, and we know if there is a classical thumb sign beta, okay, that is due to the swollen epiglottis, matlab we know it is a case of infection of epiglottis, and infection of epiglottis is known as acute epiglottitis. Please tell me beta, we know acute epiglottitis is a severe bacterial infection of the supraglottis. Which is the most common cause? Which bacteria is the leading cause of acute epiglottitis beta? Which is the leading cause of acute epiglottitis? Please remember beta, you can't zoom the pictures in X-ray basic in the examination, but you can look at the X-ray carefully. You have to make the difference. Clear about? You have to make out the difference. If you are not able to see a whitish shadow like a thumb, it cannot be a case of thumb sign. Clear about? That is what is important. So that is important beta. So acute epiglottitis, more commonly in examination, yes, it is acute epiglottitis, but not always. There can be chances in exam when they can trick you. Okay? The most common cause of acute epiglottitis which is there beta, it is nothing else but Streptococcus pneumoniae. Yes, the most common cause of acute epiglottitis overall is going to be Streptococcus pneumoniae or pneumococcus. If they say unimmunized child, what is the most common cause of acute epiglottitis in an unimmunized, that is an unvaccinated child? So whenever we have an unimmunized child beta or an unvaccinated child, what will be the leading cause of acute epiglottitis? Let me know in the chat box. Unimmunized बच्चे में the most common cause of acute epiglottitis will be HIV. Very good. So please remember basically beta, whenever there is the unimmunized child बच्चे, the leading cause is going to be HIV. That is nothing else but Haemophilus influenzae type B beta. Okay, it is going to be Haemophilus influenzae type B. Now important is if they ask you, the baby is having a bacterial infection of the supraglottis, due to which there is a lot of edema in the supraglottis beta or inflammation in the supraglottis. That's the reason patient will have problems like respiratory distress, drooling of saliva, odinophagia, hot potato voice. Okay? Along with that, the patient may have high grade fever. And which kind of stridor beta? We know as that laryngeal edema will, or the supraglottic edema will cause obstruction beta. Which kind of stridor will be noted? That was a PYQ again. Which type of stridor? Inspiratory, expiratory or biphasic? Which type of stridor is noted in patients of acute epiglottitis? Do remember here there is a inflammation or edema in the supraglottis. Very good. Whenever there is an inflammation or edema in the supraglottis, obstruction of supraglottis causes an inspiratory stridor beta. Yaad rakhna, we know whenever there is obstruction in the supraglottis and the pharynx. Okay, so whenever there is obstruction in the pharynx and supraglottis, that causes inspiratory stridor. Whenever there is obstruction at the level of glottis, subglottis and cervical trachea. Glottis, subglottis and cervical trachea obstruction causes a biphasic stridor, and any obstruction beta in the thoracic trachea or the primary and secondary bronchi. Any obstruction in the thoracic trachea or the primary and secondary bronchi causes an expiratory stridor beta. Clear? We know here this baby is going to be sitting in tripod position beta. Why? Because sitting in tripod position will give symptomatic relief to this baby beta. That's the reason the baby sits in tripod position. If they ask you in patients of acute epiglottitis, the first line investigation is always a X-ray soft tissue neck lateral view, where you are able to see the swollen epiglottis as the thumb sign. If you do a laryngoscopy, beta, on examination, when I do a laryngoscopy is not done for examination. Laryngoscopy is done for airway management. And here definitely you are able to see a classical cherry red epiglottis. On a laryngoscopy, I am able to see a very classical cherry red epiglottis due to the inflammation. If they ask you what is the first step in the management of acute epiglottitis, let me know in the chat box. The first step to manage a case of acute epiglottitis is going to be, first step in the management of acute epiglottitis is going to be, the first step in the management of acute epiglottitis, beta, is nothing else but airway management. Very good. We know, beta, that airway of the patient has to be managed. Reason, as the child will have laryngeal edema over here, that can cause an airway blockage, beta. And due to that airway blockage, the child will actually develop, okay, a severe respiratory distress. The child can land up into respiratory arrest, and that can cause child's death also. The first is always airway management, and that is usually done by a prophylactic intubation. Matlab, even if the child is not having very severe distress, beta, still go for a intubation in that child. That is known as prophylactic intubation, beta. That has to be done. Anybody, prophylactic intubation in ENT or pedia is recommended in patients of acute epiglottitis. Prophylactic intubation in surgery is recommended in patients of, let me know in the chat box. Prophylactic intubation in surgery is recommended. Kahan pe padha tha main? So please remember, an early elective intubation, not an elective, early elective intubation has to be done, or a prophylactic intubation has to be done, beta. That is important. Drug of choice, we know as it is a bacterial infection, treatment has to be, or the drug of choice has to be IV antibiotics, beta. We have to give broad spectrum IV antibiotics like third generation cephalosporins or ceftriaxone. Along with that, beta, to reduce the laryngeal edema, we can give steroids or dexamethasone. Okay, so steroids or dexamethasone to reduce the laryngeal edema. And please remember, beta, we also have to give bronchodilators like nebulization of racemic epinephrine. When we give a bronchodilator like nebulization of racemic epinephrine, it is known to cause bronchodilation. Epinephrine is a sympathetic drug, na? So it causes bronchodilation. Yes, so please remember, not only closed room burn, but any patient who is having inhalational burn. Any person of inhalational burn should always be given a always should go for a prophylactic intubation. Hopefully you remember that from surgery. Okay. Next is the case, beta. Here you are able to see that the tonsils are pushed medially, beta. You can see the tonsils have been pushed medially, and the ula is pushed towards the opposite side. The ula which is there, beta, it is pushed towards the opposite side. Why? Because there is collection of pus, beta, in the parapharyngeal spaces. We know parapharyngeal spaces are two of them. One is the peritonsillar space, and whenever there is collection of pus in the peritonsillar space, that is called as an peritonsillar abscess or a quinsy, beta. That is known as a peritonsillar abscess or quinsy. Whereas second one is going to be collection of pus in the parapharyngeal space, which is more outside or more lateral. And whenever there is collection of pus in the parapharyngeal space, that is called as parapharyngeal abscess. Differences now. We know, beta, that both the conditions where the common features are. We know in both the conditions the patient will have a high grade fever. Both the conditions where patient may have a trismus or a lockjaw. Both conditions, beta, may cause dysphagia, odynophagia like features. The difference are, we know quinsy or peritonsillar abscess is more common in adults. It is more common in adults, whereas parapharyngeal abscess is more common in children. Next important, beta, please remember that even the clinical presentation is same. Only one difference is there. What is that main difference? That is nothing else but neck swelling, beta. Please tell me, external neck swelling is only and only visible in which patients? External neck swelling is only and only visible in which patients? External neck swelling is only visible in which patients? So the external neck swelling which is there, it is only and only visible in patients of parapharyngeal abscess. Yes, only in parapharyngeal abscess the external neck swelling is present. Quinsy mein there is no neck swelling at all. Quinsy mein there is no neck swelling at all. That is what is important to remember. Clear about? So these are the important differences, beta, that you have to keep in mind. Clear? In treatment, beta, in both the conditions, obviously I can go for incision and drainage because both of them are cases of an abscess. Okay? The only major difference that you have to keep in mind, beta, it is about what? It is about the peritonsillar abscess of quinsy mein. Here there is an internal swelling, beta. That is the reason I have to go for a per oral incision and drainage. Whereas in cases of parapharyngeal abscess, yes, a neck swelling is visible from outside, so I can go for an external incision and drainage. Whereas antibiotics will be given in both the conditions, beta. Hopefully cleared all of you now. That is important. Next, question number 18. Easy question. We are having a weightlifter, beta, who presents to us with complaints of a cystic neck swelling. A weightlifter coming to you with complaints of cystic neck swelling beta, and on lateral aspect beta of the neck, on the lateral aspect of the neck since last few months. On pressing the swelling beta, we are able to hear a hissing sound beta. On pressing the neck swelling beta, we are able to hear a hissing sound. So X-ray has been performed beta, which has been given below. What is the likely diagnosis of the case below? I hope all of you are quite aware beta that if I ask you about the likely diagnosis, the question should have been likely treatment. Now, likely diagnosis of this case, first of all beta, we know patient coming to you with cystic neck swelling beta. Okay, and when you press that neck swelling, so air escapes out of that neck swelling beta, and when air goes out of the neck swelling, it makes a hissing sound like this. Is classically known as which sign? Anybody? Yes, so this is classically known as a Bryce sign beta. Whenever I press a neck swelling and that makes a gurgling sound like so please tell me beta, whenever I press a neck swelling and that makes a gurgling sound, that is classically called as which sign and seen in which condition? If I press a neck swelling and that makes a gurgling sound, that is called as which sign and seen in which condition? So please remember, that is classically known as the Boyce sign, B-O-Y-C-E. That is known as the Boyce sign and seen in patients who are suffering from Zenker's diverticulum. Okay? So it is a Boyce sign seen in the patient suffering from Zenker's diverticulum beta when there is a pharyngeal pouch. Yes. Now important is X-ray of this patient has been given below beta, and here you are able to see a air-filled cystic neck swelling beta arising from the larynx. So air-filled cystic neck swelling. We know in the larynx beta we have a structure between the false and the true vocal cord. Okay? So the structure that is present in between the false and true vocal cord is known as ventricle, and from that ventricle we have an outpouching called as saccule. Whenever there is lot of pressure in the larynx beta, okay, then there is an abnormal dilatation of saccule, and that abnormal dilatation of saccule is called as a laryngocele beta. So this is a classical diagnosis of condition known as laryngocele. Okay, this is the classical condition of laryngocele. हमें पता है सरकारी question of laryngocele starts as what? सरकारी question of laryngocele starts beta as a trumpet player. हमें पता है that sarkari question of laryngocele will start as trumpet player. Reason, all those patients beta who are going to play wind instruments beta, where you have to blow in a lot of air, they will have a constantly high pressure inside the larynx beta. So usually trumpet players, shehnai players, these people will always have constantly high pressure. Even weightlifters beta, weightlifter fill up air while lifting the weight beta, so they will also have high pressure inside the larynx, and that is the reason the patient will have abnormal dilatation of saccule leading beta to nothing else but a case of laryngocele बच्चे. Clear? So the patient will have a laryngocele, and laryngocele के लिए investigation is done by X-rays or a CT scan with the Valsalva manure to make the swelling more prominent. What is the likely treatment beta? Now what should be the likely treatment in this condition? We know likely treatment of this condition has to be option C beta, that is nothing else but surgical excision. You have to surgically excise beta the laryngocele or the abnormally dilated saccule. Dohlmann's procedure, which we know, Dohlmann's procedure is usually done beta for the treatment of Zenker's diverticulum. That is a diverticuloesophagostomy that we do in Zenker's diverticulum. Cyst trunks operation, surgery se bolo. Cyst trunk operation is done for the treatment of, let me know in the chat box. Cyst trunks operation, we do it for which condition? Cyst trunks operation, we do it for which condition? Yes, so please remember, thyroglossal cyst or a thyroglossal fistula. Thyroglossal cyst or a thyroglossal fistula के लिए we have to do a cyst trunk surgery where we have to definitely remove beta the we have to remove beta the thyroglossal cyst along with the thyroglossal tract along with the part of hyoid bone. That is what is cyst trunk surgery. Chemoradiation is not done over here beta. It is not a case of any cancer. Yeah. Now here you are able to see identify the swellings one by one. First of all, if I talk about beta anterolateral neck swelling, as you are able to see beta in the first picture, I am able to find an anterolateral neck swelling along anterior border of the patient's sternocleidomastoid muscle. So anterolateral neck swelling beta along the anterior border of sternocleidomastoid muscle beta. Okay. This is a classical case of which condition? Along the anterior border of sternocleidomastoid, patient is having this swelling beta. Yes, this is a classical case of nothing else but a branchial cyst beta. We have discussed in surgery. This is a classical case of branchial cyst. Alright, now branchial cyst happens due to persistence of which embryological structure? In which embryological structure, if there is collection of fluid beta, then the patient is actually going to develop a branchial cyst. Bolo. Branchial cyst is going to develop beta if the patient is going to have persistence of which embryological structure? So whenever there is collection of fluid beta inside the cervical sinus, so inside the cervical sinus, बच्चे, whenever there is collection of fluid, that leads to a formation of branchial cyst. We know branchial cyst mein the treatment is nothing else but a surgical excision. So a surgical excision, okay, yes, not from the second arc exactly, from the second pouch, sorry, so second cleft, ठीक है. The treatment is nothing else but surgery or surgical excision. Next important, if they ask you, here I am having a patient with complaints of midline neck swelling. So my patient comes to me with a complaint of midline neck swelling beta, and this midline neck swelling which is there, it is very classical. Why? Because it moves with deglutition. That means whenever the patient tries to swallow something beta, it moves with that. So it moves with deglutition. Second important beta, it also moves with protrusion of tongue. ठीक है, it moves with deglutition, whereas it also moves with protrusion of tongue beta. So whenever the midline neck swelling moves with deglutition or the protrusion of tongue, then please tell me beta, what should be the classical diagnosis? Yes, very good. So please remember beta, midline neck swelling which moves with deglutition or protrusion of tongue beta, that means there is collection of fluid in a patent thyroglossal tract beta, and the diagnosis of this case is nothing else but a thyroglossal cyst. And as this cyst is connected with the tongue, therefore it moves with protrusion of tongue beta. Investigation of choice is an ultrasound plus FNSE beta, and treatment I've told you it is surgical, a cyst trunk operation beta, which is surgical excision. Cyst trunk operation has to be done. Third important beta, a neonate patient presenting to you bache with a posterolateral neck swelling. A neonate has been brought to you beta with a posterolateral neck swelling bache. So there is a neck swelling in the posterior triangle of neck. You see that the trans illumination test in this swelling is positive. Matlab when you flash a torchlight beta, the whole swelling glows with light bache. The trans illumination test, okay, the trans illumination test in the swelling is positive. Why? Because the swelling may be containing a clear fluid beta inside it, and that's the reason the trans illumination test is positive. So yes, it is a classical diagnosis of which condition? It is a classical diagnosis beta of nothing else but a case of a cystic hygroma. Cystic hygroma is nothing else but beta a lymphatic sequestration cyst. Okay, cystic hygroma is a lymphatic sequestration cyst beta which is formed in the patient. And याद रखना, cystic hygroma की अगर मैं बात करूँ, treatment is again a surgical excision beta. Treatment for a cystic hygroma is again a surgery or a surgical excision. Hopefully clear to all of you now. That is important beta. ठीक है, cystic hygroma is commonly associated with which aneuploidy? Let me know that in the chat box. Commonest association of cystic hygroma is seen with which aneuploidy beta? Let me know that in the chat box. Which aneuploidy is very commonly associated with cystic hygroma? Now if I talk about question number 19 beta, here they say, anybody, which aneuploidy is commonest association of cystic hygroma? Anybody? So याद रखना, the commonest aneuploidy that is associated with cystic hygroma is nothing else but Turner's syndrome beta, 45X. So Turner's syndrome is the commonest association basically of cystic hygroma. That has to be remembered. Clear है बात? Next question number 19 अगर वो पूछेंगे, तो do remember that here a patient was diagnosed beta with cancer larynx stage 3. The patient was diagnosed with cancer larynx stage 3, and therefore the patient was planned for a laryngectomy beta along with radical neck dissection. Now they are asking you which among the following structures which are not removed in the radical neck dissection. Which structure will not be removed beta in a radical neck dissection? They are asking you. Now if I talk about CA larynx, we know beta CA larynx will be adenocarcinoma or squamous cell carcinoma. Let me know in the chat box once. CA larynx or cancer larynx will be commonly a adenocarcinoma or squamous cell carcinoma. We know CA larynx happens in around 40 to 60 years of males beta. The 40 to 60-year-old male is more commonly affected. Reason is smoking and alcohol are the commonest risk factors beta. Okay, even HPV infection, that is human papilloma virus infection 16 and 18 are commonly associated with CA larynx. We know most common site of CA larynx is going to be the glottis, that is your true vocal cord. The glottis or the true vocal cord is the most common site beta for a cancer larynx to develop. That is what is important to be remembered. And that's the reason, yes, very good. The most common type of CA larynx has to be squamous cell carcinoma. Reason beta, we know the whole larynx is lined by ciliated pseudo-stratified columnar epithelium, but the true vocal cords or the glottis are lined by stratified squamous epithelium beta. That's the reason definitely the most common type is going to be squamous cell carcinoma, because glottic cancer is the most common type beta. Okay. Important is whenever the patient will have glottic cancer beta, it will have the best prognosis. Reason, anybody? Why glottic cancer will always have the best prognosis? Glottic cancer will always have best prognosis. One, because it causes hoarseness of voice very early beta, and that's the reason the patient goes to the doctor very early and the condition is diagnosed early. One reason is that the condition gets diagnosed early. And yes, another reason to have a best prognosis beta, because glottis or the true vocal cords does not drain into any lymphatics, and that's the reason there is no lymphatic metastasis beta if the patient is suffering from a glottic cancer. Very good. So that is what is important to remember. Shabash. If they ask you investigation of choice, we know it has to be a direct laryngoscopy and biopsy beta. So direct laryngoscopy with biopsy is the investigation of choice in cases of CA larynx. If they ask you now the staging beta, I have told you CA cervix, CA breast and सी लैरिंग्स की स्टेजिंग पता होनी चाहिए. तो इफ आई टॉक अबाउट T1 बच्चे, वी नो दैट T1 मतलब only one structure is involved. So whenever only one structure is involved beta, that is T1. In this if I say T1A beta, that is going to be one vocal cord involvement, and T1B बच्चे, that is both the vocal cord involvement. So T1A means one vocal cord and T1B means both the vocal cord. T2 means when more than one structure is going to be involved. T2 means when more than one structure is involved beta. T3 means when the vocal cords are fixed or immobile. Okay, whenever the vocal cords will get fixed or they will become immobile beta, that is T3. याद रखना, vocal cords if they are mobile, that is T1. ठीक है, if the mobility of the vocal cord is intact beta, so that is what is going to be T1. That is what is important. No issues with this. याद रखना. And T4 means whenever there is an extra laryngeal extension beta. So whenever there is an extra laryngeal extension, मतलब whenever the cancer spreads outside the larynx, that is what is going to be T4. Hopefully clear to all of you now. याद रखना. These are the important points that you have to remember. Shabash. Now important, we have also discussed about the nodal metastasis and all. याद रखना, but treatment depends whether it is which kind of T staging beta. If I say beta patient is having a T1 or T2 stage का laryngeal cancer, so T1 or T2 stages of laryngeal cancer में what is the treatment of choice? So T3 में it can be other structures also, not necessary that only vocal cord is involved. T3 में it could be other structures also, but more importantly you have to remember that vocal cord should be fixed. Okay, it can be only vocal cord involvement, it can be supraglottis involvement also, no issues with that. T1 and T2 में beta the only treatment is radiotherapy. Please remember the treatment in cases of T1 and T2, that is early stages, is only radiotherapy. Reason, total laryngectomy beta is not feasible in early stages. ठीक है. T3 and T4 if they ask you, then T3 and T4 में we can go for surgery, and the T3 and T4 में the surgery that we do is known as a total laryngectomy. We have to go for a total laryngectomy beta. And apart from total laryngectomy, do remember that we have to also do a modified radical neck dissection. The total laryngectomy plus a MRND. MRND means we know modified radical neck dissection, and followed by that we have to give radiotherapy. So in T3 and T4 stages, as the cancer is in the advanced stages beta, we have to do a total laryngectomy along with modified radical neck dissection if necessary, and along with that definitely beta we have to give radiotherapy to prevent any recurrence. Clear? But that is important. Now please remember beta that modified radical neck dissection or radical neck dissection means removal of the lymph nodes beta. We know if the cancer is in the stage 3 beta, obviously the lymph nodes will be involved or other structures will be involved, and for removal of all those structures beta we have to go for a radical neck dissection as well. Okay, so here they are saying radical neck dissection, not the modified one. So radical neck dissection mein what are the structures removed? First we know two glands we have to remove beta. One is going to be the okay, so first is going to be beta the submandibular gland. Sorry, the first is going to be a submandibular gland, and second is going to be a tail of parotid gland beta. So submandibular gland or a tail of parotid gland, these are the two structures beta which we have to remove during a radical neck dissection. Second, we have to remove level 1 to level 5 lymph nodes bachche. We have to remove level 1 to level 5 lymph nodes. I hope all of you are quite aware there are total 7 levels of lymph nodes. I have been telling that you in ENT and surgery beta. Yaad rakhna, these are the 7 levels of lymph nodes I have told you. Level 1 will be submental and submandibular. So level 1 are submental and submandibular. Level 2 are definitely upper deep cervical, that is located behind the hyoid bone, which was a recent FMG question in FMG Jan. Clear? So level 2 are the upper jugular lymph nodes, you can call them as, or definitely the upper deep cervical lymph node. Level 3 will be the middle deep cervical lymph nodes beta. Level 4 will be the lower deep cervical lymph nodes beta. Level 5 are the posterior triangle lymph nodes beta. So level 5 are the posterior triangle or the supraclavicular lymph node. Level 6 are the pretracheal or the prelaryngeal, that is the central or anterior group of lymph nodes. The anterior group of lymph nodes which are there beta, those are going to be level 6, that is important. And level 7 which are there beta, those are the superior mediastinal lymph node. Okay, level 7 are the superior mediastinal lymph node. Clear? So we know level 1 to level 5 we have to remove these lymph nodes beta. Anybody let me know in the chat box. Okay, we have discussed in ENT surgery both that what is the removal of level 6 lymph nodes called as. If I remove the level 6 lymph nodes separately, what is that called as? Level 1 to 5 are removed in radical neck dissection or modified radical neck dissection. Next, we have to remove two muscles beta. One is the omohyoid muscle, second is the sternocleidomastoid muscle. We have to remove two muscles, one is omohyoid, second is sternocleidomastoid beta. Third important, if they ask you, apart from these structures beta, we also have to remove the 11th cranial nerve known as accessory nerve. We also have to remove the 11th cranial nerve known as accessory nerve, and we also have to remove the next one, and that is nothing else but the internal jugular vein. We also have to remove the IJV, that is internal jugular vein beta. Okay, so that is important. Modified radical neck dissection, which is there definitely. In that beta there are three types. Okay, type 1 mein we try to save the accessory nerve. Type 2 mein we save the accessory nerve and the internal jugular vein. Type 3 mein we save the accessory nerve, internal jugular vein along with sternocleidomastoid muscle. Please let me know in the chat box. Removal of level 6 lymph nodes beta. The anterior or the central group of lymph nodes. Removal of these level 6 lymph nodes which is usually done in thyroid cancer. It is known as which dissection? So here we know at radical neck dissection or modified radical neck dissection, whatever you do beta, you never remove the sublingual node. So sublingual gland. So please remember here they have asked you at which structures are not removed beta. So we know that the structure that will not be removed will be the sublingual gland. It is never removed in a radical or a modified radical neck dissection. What is the removal of level 6 lymph nodes called as? What is the removal of level 6 lymph nodes known as? Level 6 lymph nodes are present in the anterior or the central part of the neck. Yes, it is known as central neck dissection. Please remember that. Central neck dissection is done for the level 6 lymph nodes in patients of thyroid cancer. Clear? Question number 20 now. Okay, question number 20 says beta. Okay, here we are having a young man who presented to us beta with a unilateral hearing loss. A young man presented to us with complaints of unilateral hearing loss and tinnitus, that is a ringing sensation in the ear. Histology image has been shown below. What is the likely diagnosis? We know beta patient was having a unilateral hearing loss. They have not mentioned whether it was conductive or sensory neural, but as the patient was having tinnitus, so we can suspect that it could be a sensory neural hearing loss. Okay, though we are not sure about it. That can be assessed with the help of an audiometry itself. Here, if I talk about bache, very good. If I talk about this picture, here you are able to see beta. This is the classical presentation of histopath, which is actually going to show you the antony B bodies. Very good. Either you can call them as antony B bodies, also known as the Verrucay bodies beta. These are the antony B or the Verrucay bodies. If I talk about the Verrucay bodies, anybody, Verrucay bodies on histopathological examination is a classical feature of which condition? Verrucay bodies on histopathological examination is a classical feature of which tumor? It is a classical feature of Verrucay bodies on histopathological examination beta. Is a classical feature of which tumor? Here you can see the malignant cells are arranged, and in between that beta we are able to see a necrosis like picture. So these are known as the Verrucay bodies or antony B bodies, and this is a classical feature of, very good. It has to be a classical feature of nothing else but beta. Option B, that is a vestibular schwannoma, also known as an acoustic neuroma. So it is a classical feature of an acoustic neuroma or a vestibular schwannoma, which is a benign tumor arising from the 8th cranial nerve, the vestibulocochlear nerve, due to which the vestibulocochlear nerve gets damaged and the patient has a unilateral sensory neural hearing loss beta. Okay, all cases में acoustic neuroma or vestibular schwannoma is unilateral, except in which is the condition where acoustic neuroma is going to be bilateral. Let me know that in the chat box. Only condition where acoustic neuroma is bilateral. We know it is usually a unilateral slow growing tumor beta, okay, of the 8th cranial nerve, and we know it is going to arise at the level of cerebellopontine angle. That's the reason we can even say that acoustic neuroma is the most common cerebellopontine angle tumor. Most common cerebellopontine angle tumor is also acoustic neuroma, so it is actually a brain tumor beta. Okay, important is here the patient will come to you with a complaint, as I've told you beta, with unilateral sensory neural hearing loss. Along with that, as the 8th nerve is damaged, we know 8th nerve is also responsible for balance. So definitely the patient is also going to have imbalance or vertigo like features. So unilateral SNHL, imbalance, tinnitus, these are the features beta. Along with that, for investigation, if they ask you beta, what is this investigation done? Yes, please remember that only neurofibromatosis type 2, only neurofibromatosis type 2 is the condition which is जहाँ पे acoustic neuroma is going to be bilateral, otherwise it is always unilateral. Bolo. Let me know in the chat box what is the investigation of choice for acoustic neuroma. The investigation of choice for acoustic neuroma is going to be, investigation of choice for acoustic neuroma is going to be a, please tell me, acoustic neuroma may definitely. Very good. And gadolinium enhanced MRI is going to be the investigation of choice. So gadolinium enhanced MRI beta has to be the investigation of choice because it is a brain tumor or a tumor arising from the cranial nerve beta, and that's the reason MRI has to be done. And when we do MRI, which is the classical feature seen at the cerebellopontine angle, ये cerebellopontine angle है ना, at the cerebellopontine angle, what is the classical picture on the gadolinium enhanced MRI? The classical picture on a gadolinium enhanced MRI. Very good. It is classically known as which sign? The ice cream cone appearance or the ice cream cone sign. So the classical, it is known as the ice cream cone appearance or ice cream cone sign beta. That is a classical feature in patients of gadolinium enhanced MRI beta, in patients suffering from acoustic neuroma. Ice cream cone appearance is going to be seen. And we know beta, the treatment in patients of acoustic neuroma is nothing else but surgery or surgical excision. So treatment is surgery or a surgical excision beta for the treatment of acoustic neuroma. Clear about neurofibroma is a tumor beta which is usually seen on the skin. Okay, more commonly it can be seen arising from the nerves also. Okay, but more commonly seen on skin. It is seen in patients suffering from neurofibromatosis. Okay. It is not a picture of neurofibroma beta. Next is leiomyoma. Leiomyoma is a smooth muscle tumor beta that doesn't have any verrucate bodies. Rhabdomyoma is a skeletal muscle tumor again. Clear about that is what is important to remember. Yeah. Next important, if they ask you about this question beta, which states a patient following a total thyroidectomy beta started experiencing difficulty in breathing beta. The patient was having a post-operative respiratory distress beta. Patient is having a difficulty in breathing and repeated attempts to extubate beta were unsuccessful. You have tried extubating the patient for a lot of time, but it was unsuccessful. You cannot remove the ET tube. Reason is maybe beta the vocal cords of the patient would have been closed, and that's the reason why there is respiratory distress or difficulty in extubation. The most probable cause is going to be, what is going to be answer? Very good. So I hope all of you are quite aware beta about this condition. Okay, shabash. It is nothing else but beta a case of bilateral adductor palsy or abductor palsy. It is a classical case of a bilateral abductor palsy. Now whenever I say beta there is a bilateral abductor palsy, matlab we know there is only single abductor muscle in the larynx, and that single abductor muscle of the larynx is called as PCA, called as posterior cricoarytenoid. Matlab on both the sides the posterior cricoarytenoid muscle has been paralyzed, इसलिए the vocal cords cannot get abducted beta. They will remain in a closed state, that is in the adducted position. And we know that posterior cricoarytenoid muscle or the abductor muscles are usually supplied or innervated by the recurrent laryngeal nerve. So whenever the person is having a bilateral abductor palsy, the reason is nothing else but a bilateral recurrent laryngeal nerve injury. The cause is a bilateral RLN or a bilateral recurrent laryngeal nerve injury. But we know beta that all the intrinsic muscles of vocal cords or all the intrinsic muscles of the larynx are usually supplied by recurrent laryngeal nerve only, except cricothyroid. In this patient, what happens beta, that all the muscles of the larynx will get paralyzed except cricothyroid beta. The only working muscle of larynx is cricothyroid, and we know cricothyroid is not only a tensor muscle beta, it is also an adductor muscle. As it is an adductor muscle, therefore it causes adduction or closure of the vocal cord. As there will be a closure of vocal cord, the patient is actually going to complain of respiratory distress beta, okay, as the vocal cords are closed. And second, there will be a noisy breathing known as stridor. Okay, so there will be respiratory distress and stridor, but the patient will be able to produce the voice beta. There is no loss of voice, there is no aphonia in this patient. Now treatment ke liye, please tell me what should be the emergency management. What is an emergency management? Airway management has to be done because patient comes to you with respiratory distress. What should be done for an emergency airway management in patients of bilateral abductor palsy? So bilateral abductor palsy means the airway management should be done by, so very good, it has to be done by tracheostomy beta. Reason is we know both the vocal cords are closed beta, so obviously intubating the patient is not a choice at all. So we have to go for a tracheostomy which is for airway management. That is the first line treatment beta. But if they ask you definitive management, the definitive management is nothing else but a type 2 thyroplasty beta. So we know whenever I do a type 2 thyroplasty, that is nothing else but lateralization of vocal cord. So type 2 thyroplasty or a lateralization of vocal cord has to be done. That is the definitive management for bilateral abductor palsy, not type 1, type 2 karte. Next important, if I talk about basically beta, that is nothing else but a bilateral adductor palsy. Whenever I talk about a bilateral adductor palsy beta, please remember bilateral adductor palsy mein what will happen, all the adductor muscles of both the vocal cords are paralyzed. We know that what is the cause of bilateral adductor palsy, let me know in the chat box. Now if I talk about basically beta, the adductor palsy, we know there are 4 adductor muscles which are present in the vocal cord. One is the thyroarytenoid muscle, second is an interarytenoid muscle, third is lateral cricoarytenoid muscle, and fourth cricothyroid muscle. These 4 are the adductor muscles of vocal cord. We know 3 of them beta, the first 3, that is thyroarytenoid, interarytenoid and the lateral cricoarytenoid, are supplied by the recurrent laryngeal nerve, but the cricothyroid muscle is supplied by the external branch of superior laryngeal nerve. So when they say beta there is a bilateral adductor palsy, so do remember the cause is nothing else but a bilateral RLN plus SLN injury. Then the cause is actually going to be a bilateral RLN plus SLN injury, or we can say a complete vagal paralysis, because both of these are branches of vagus nerve. So either the cause is a bilateral RLN plus SLN injury, or it is going to be basically beta a case of a complete vagal paralysis. Hopefully clear, that is important. If they ask you what will be the complaint, we know here as all the 4 adductor muscles are paralyzed beta. See, bilaterally if the recurrent laryngeal nerve and superior laryngeal nerve both have been damaged beta, obviously that means all the muscles in the vocal cord will stop working, and if all the muscles of larynx will stop working beta, so please remember the vocal cords will come in a intermediate position, that is a cadaveric position. Just like a cadaver beta, the vocal cords will be partially open, and when the vocal cords will be partially open beta, the patient will not be able to produce voice. That means the patient will complain of aphonia. Second important beta, as the vocal cords will constantly remain open, the patient will have a high risk of recurrent aspiration. So aphonia and recurrent aspirations beta will be the complaint of the patient, but as the vocal cords are open, the patient will not experience any respiratory distress beta. Clear about? If they ask you treatment, as the patient is not having respiratory distress, we don't need an emergency management beta. We can easily go beta for a definitive management. And that definitive management is a type 1 thyroplasty. That is nothing else but medialization of vocal cord. So the definitive management is a type 1 thyroplasty known as medialization of vocal cord. Hopefully cleared all of you now. That is important. यहाँ पे after a total thyroidectomy surgery beta, okay, patient was experiencing difficulty in breathing, that is respiratory distress, and repeated attempts to extubate were unsuccessful beta. Extubation is not happening. Why? Because if the vocal cords are closed, it is difficult to remove the endotracheal tube beta. So we know that whenever there is a post-op respiratory distress bache, or whenever extubation becomes difficult, we know it is a case of bilateral abductor palsy, and that happens due to bilateral recurrent laryngeal nerve injury. The answer to this question has to be option B beta. That means it is a case of a bilateral recurrent laryngeal nerve palsy. Unilateral recurrent laryngeal nerve palsy will only cause hoarseness of voice beta. Okay, unilateral recurrent laryngeal nerve palsy will only lead to hoarseness of voice. Anybody which sided recurrent laryngeal nerve is more commonly injured or more commonly paralyzed? Unilateral recurrent laryngeal nerve palsy में which sided recurrent laryngeal nerve is more commonly paralyzed? Let me know in the chat box. Tension hematoma definitely beta can be one of those causes, okay, which can also cause the difficulty in breathing beta. Okay, so tension hematoma can also be one of the causes beta which can actually cause difficulty in breathing bache. Okay, but another condition is going to be SLN palsy. SLN palsy doesn't cause any kind of difficulty in breathing. What happens? We know SLN has two branches beta. One is going to be ILN, that is internal laryngeal nerve. Second is going to be ELN, that is external laryngeal nerve. Now we know the internal laryngeal nerve of the internal laryngeal nerve which is there beta, it is known to carry sensations from supraglottis. So whenever beta there will be an internal laryngeal nerve palsy, the patient will have no sensations in the supraglottis. If the patient will have no sensations in the supraglottis beta, there will be no foreign body sensation, and that's the reason the patient will have recurrent aspiration. So whenever the patient's internal laryngeal nerve is injured, patient has recurrent aspiration. Whereas we know the external laryngeal nerve or the external branch of superior laryngeal nerve is known to supply the cricothyroid muscle. If the external laryngeal nerve is known to supply the cricothyroid muscle beta, so we know what is going to happen. If the external laryngeal nerve is injured, the cricothyroid muscle will undergo palsy. And we know cricothyroid muscle is not only an adductor muscle beta, but it is the main tensor muscle of vocal cord, which is known to give better quality of voice. It stretches the vocal cord and gives the better quality of voice. But when the external laryngeal nerve is paralyzed beta, we know cricothyroid muscle will also undergo palsy. Due to that, the vocal cords will become loose, and whenever the vocal cords will be loose beta, that will cause a poor quality of voice. So whenever there is a SLN palsy beta or a superior laryngeal nerve palsy, patient will have both these symptoms, recurrent aspirations along with poor quality of voice. Please tell me if they ask you beta that what is the answer to the previous year question where they said beta, the question was a patient comes to you after a total thyroidectomy surgery, and now the patient is going to have recurrent aspirations with a normal quality of voice. Which is the likely nerve injured? Patient after a total thyroidectomy surgery comes to you with complaints of recurrent aspiration with a normal quality of voice. What is the likely nerve injured? ELN, RLN, SLN or ILN? What has to be the likely nerve injured in this condition? Complaints of recurrent aspiration with normal quality of voice. Yes. The answer to this question has to be only ILN beta, because we know whenever the internal laryngeal nerve will undergo damage, then only the patient will have recurrent aspiration. And if there is normal quality of voice, that is suggestive that the external laryngeal nerve has not been injured. Clear about that is important. Which is the most common nerve injured after total thyroidectomy surgery? After thyroid surgery, the most common nerve injured, let me know in the chat box. It is which nerve which is the most common nerve injured after total thyroidectomy? Options are ELN, ILN, SLN or RLN. Which is the most common nerve injured after a total thyroidectomy surgery? Yes. So yaad rakhna beta, the most common nerve that is injured after a total thyroidectomy surgery, the answer has to be ELN. Very good. That is external laryngeal nerve and not the recurrent laryngeal nerve. Okay, so ELN followed by RLN has to be your answer beta. Clear? That is important. Question number 22. Here they say beta, we are having a 6-year-old boy bache who presented to us with a recurrent upper respiratory tract infection along with poor growth beta and a high arched palate. Okay. The child is also having impaired hearing or difficulty in hearing beta, that is hearing loss. Tympanogram is given as follow beta. What would be the most appropriate management of the patient? Bolo. What is the provisional diagnosis you are thinking about beta? What is the provisional diagnosis you are thinking about? What is the provisional diagnosis? We know beta that the patient is a school age child bache. a 6-year-old boy having a history of recurrent upper respiratory tract infection. Whenever a school-age child has upper respiratory tract infections on a recurrent basis, what is going to happen? In the middle of his nasopharynx beta, we know that the adenoids which are there, these nasopharyngeal tonsils called as adenoids, will undergo hypertrophy. When these adenoids will undergo hypertrophy beta, both the eustachian tubes, bilateral eustachian tubes, will get blocked, due to which the middle ear will not be able to drain the secretions beta. And that's the reason definitely what is going to happen, the baby will have a glue ear, and due to that glue ear the child is having difficulty in hearing or impaired hearing. So we know, as the child is a school age child with recurrent upper respiratory tract infection along with the classical high arc palate, which is a feature of adenoid facies, and impaired hearing which can occur due to glue ear beta. It is a classical case of adenoid hypertrophy, which it is a classical patient of adenoid hypertrophy. Okay. And adenoid hypertrophy is not only there beta, along with adenoid hypertrophy there is a complication, that is glue ear. The patient is having a adenoid hypertrophy along with the complication of glue ear beta. That is important. Why I am saying it is a confirmed case of glue ear? Reason beta, we know adenoid hypertrophy causes glue ear, but they have said there is impaired hearing. And second important feature beta, they have given a tympanogram which is very much suggestive of glue ear. Why? Here you are able to see a tympanogram beta on a tympanometry. You are able to see which kind of a curve. What kind of curve is this? On the tympanogram beta, which kind of curve that you are able to see? Very good. Here you are able to see beta on a tympanogram, there is a flat curve, that is nothing else but a type B curve beta. Recent FMGE question. The type B curve or a flat curve which is there beta, it is observed on a tympanogram. So whenever a type B or a flat curve is observed on tympanogram, that is a case of glue ear beta. Another condition where a flat curve is seen is tympanic membrane perforation. Yeah. So it is a case of adenoid hypertrophy with glue ear or serous otitis media. What should be the management of the patient? Let me know in the chat box. What should be the management of the child? What is going to be the management of the child? Bolo. Yes, the management of the child has to be what? A, B, C or D. We know beta, option B says myringoplasty. So myringoplasty is completely out of question because myringoplasty means repair of tympanic membrane. It is usually done in tympanic membrane perforations beta, either a traumatic one or an infective one. That is out of question. Option C says inhaled steroids and myringotomy. Please remember beta, steroids are usually given in allergic conditions beta. Okay, whenever the child will have allergic rhinitis, in those conditions we give inhaled steroids beta, and along with that we can do a myringotomy bache for drainage. But here the problem is not allergic rhinitis causing edema leading to a eustachian tube blockage, but rather here the problem is more likely to be a case of adenoidectomy beta, which is actually causing this, adenoid hypertrophy beta, which is causing this problem. Okay, so the better answer to this question has to be option D, that is nothing else but adenoidectomy with grommet insertion. Why? Reason, we know the main problem is the adenoid hypertrophy, so we have to excise the hypertrophied adenoids. Then we have to make an incision on the tympanic membrane called as myringotomy, and we have to drain all the fluid that is collected. Okay, and after that, in that myringotomy incision itself, I have to insert a grommet. Okay, now the better answer would have been adenoidectomy with myringotomy with grommet insertion. But even if they do not mention myringotomy, we have to remember that myringotomy comes by default. Why? Grommet insertion is done by myringotomy only, na? So without myringotomy, you cannot go for a grommet insertion. Why option A would wrong? Why option A would be wrong? Myringotomy and grommet insertion is only the treatment of glue ear. I have told you, if you only treat the glue ear and not the adenoid hypertrophy, patient will have a recurrence of glue ear. Wapas the patient will develop a glue ear. So the better answer is always a adenoidectomy beta. Clear about? So that is the reason answer has to be option D. That has been a PYQ. Okay, so this is the classical picture of an adenoid facies. Whenever the child is going to have an adenoid hypertrophy, these classical adenoid facies will be present in the child. There will be a high arc palate beta. As you are able to see beta, the child will have a high arc palate, and due to that high arc palate beta, more curvature in the palate, the child will have crowding of teeth beta. Okay, the child will have malocclusion of teeth or crowding of teeth which will be there. Third important, the child will have open mouth bache, and the child will have a pinched up nose. Okay, so please remember, a pinched up nose, high arc palate, crowding of teeth and open mouth beta. These are the features that you are able to see in adenoid facies, which is a classical feature of adenoid hypertrophy beta. Hopefully clear to all of you now. So that is what is important to be remembered. Okay, and whenever the patient of adenoid hypertrophy will develop a bilateral eustachian tube blockage, that will lead to development of glue ear. And whenever the child will have a glue ear beta, this is the classical otoscopic image. What is seen on the otoscopy? You are able to see this fluid beta, and this fluid contains some air bubbles which it. Okay, there are some air bubbles inside the fluid. So here I am able to see fluid behind a intact tympanic membrane. there is a fluid behind an intact tympanic membrane. Now if the question is beta that if I'm able to see red or a congested tympanic membrane with blisters on the surface, if I'm able to find beta, I've told you a common differential could be another condition जहाँ पे you may be able to see beta a red or an inflamed tympanic membrane with blisters on the surface of tympanic membrane. Okay, what is that condition called as? It is due to a viral infection. Called as which condition? Let me know in the chat box. A viral infection causing beta inflammation of the tympanic membrane, red congested tympanic membrane with blisters on the surface of the tympanic membrane. That condition is actually known as what condition? It is a classical case of, yes, bullous myringitis beta or myringitis bullosa. That is a viral infection of tympanic membrane. Clear about? Next important is this picture. Here you are able to see beta a case where you are able to see that the grommet insertion is done in the anteroinferior quadrant. We know myringotomy for grommet insertion is done in the anteroinferior quadrant of tympanic membrane. This inserted tube which is there beta is the middle ear ventilation tube called as grommet. Okay, so this is the grommet insertion which is done. Okay, so that is important to remember. These are the tympanometry curves beta. If I talk about the tympanometry curve, so yaad rakhna the first one, that is the green curve that you are able to see. Okay, we know tympanometry is what? Tympanometry is that investigation beta, also called as an impedance audiometry. In this tympanometry, we will check the freedom of movement beta of the ear ossicles or the tympanic membrane. When you check the freedom of movement of the tympanic membrane and ear ossicles, that investigation is known as tympanometry. Here you can see type A curve which is there beta. Here there is a adequate movement of the tympanic membrane beta. Matlab the tympanic membrane or the ear ossicles, okay, they are moving adequately. So this is a type A curve known as the normal curve. So the type A is going to be a normal curve. Next, the orange curve that you are able to see, that orange curve that we are able to see here, there is less movement which is seen in the tympanic membrane or the ear ossicles. Why? Because in this condition the ear ossicles have got fixed beta. So whenever the ear ossicles will get fixed, basically that condition mein you will be able to see beta. Okay, in that condition you will be able to see the curve is going to be, okay, very small in height. So if there is a very shorter curve beta, that is called as type AS curve. And type AS curve is seen in which condition? We know it is seen in those conditions wherever the ear ossicles have got fixed beta. Whenever there is fibrosis or sclerosis around the ear ossicle, and fibrosis or sclerosis around the ear ossicle is seen in otosclerosis. We know in otosclerosis, due to fibrosis, the foot plate of stapes gets fixed and therefore the movement of ear ossicle is going to decrease beta. So type AS curve is seen in otosclerosis, S for sclerosis or shadi that I've told you. Next important is going to be beta type AD curve. So here you are able to see a type AD curve. Here you can see excessive movement of the ear ossicles beta. Here the ear ossicles are able to move very freely. Why the ear ossicles are able to move very freely over here? Reason, the ear ossicles have got dislocated from each other. As the ear ossicles have got dislocated from each other beta, so there is excessive movement of the ear ossicles that you are able to see. That is called as a type AD curve. So we know better that type AD curve is usually seen in patients of ossicular dislocation. So D for dislocation or divorce, as I told you. The ossicular dislocation, whenever it is there beta, we will be able to see more movement of the ear ossicles, and that is a case of ossicular dislocation. Next, type B curve. We know better that this type B curve is a flat curve that you are able to see, and this type B curve, the flat curve, I have told you it is seen in two conditions. The two conditions jahan pe the type B or the flat curve is seen. One is definitely a case of gluvia. Second is a case of tympanic membrane perforation. So one is gluvia, second is tympanic membrane perforation. These are the two conditions beta where we are actually able to see a type B or a flat curve. And the last one that you are able to see, this red color curve that you are able to see beta, it is seen on the negative side. Okay, when the red color curve is seen on the negative side, that means the tympanic membrane is getting retracted beta. Barabar? So whenever the tympanic membrane moves inside, that is retraction. At that time you are able to see a negative or a type C curve. Negative or a type C curve is seen beta when the tympanic membrane is retracted, and retraction of tympanic membrane happens when there is a negative pressure inside the middle ear cavity beta. Whenever there is a negative pressure inside the middle ear cavity, yes, it is seen in patients of eustachian tube blockage. Whenever there is a eustachian tube blockage, the middle ear ventilation doesn't happen, and therefore there is a negative pressure which develops inside the middle ear beta. And that's the reason definitely beta, okay, the patient is actually going to have a type C or a negative curve. Okay, so that is important to remember. No issues with this, anybody? Yeah, next is question number 23 beta, Sarkari question of the FMGE exams. So here the question says a post-COVID patient who is a known diabetic beta. So post-COVID patient who might have taken high doses of corticosteroids, so the patient is at a high risk of infection. Along with that, the person is also diabetic, so even higher risk beta. Develops a unilateral facial pain beta. Along with unilateral facial pain, the person is also having loosening of teeth beta. along with the unilateral facial pain, बच्चे, the patient is also having loosening of teeth. Which investigation beta would you do to confirm the diagnosis of this patient? Which investigation बच्चे will we do basically to confirm the diagnosis of the patient? So to confirm the diagnosis of the patient beta, we have to do a gold standard investigation बच्चे. What is the investigation of choice of the gold standard investigation which will confirm the diagnosis of the case? Anybody? Bolo. We know it is a classical case beta where the patient is immunocompromised. He is a post-COVID patient, might have taken a lot of high dose steroids, and the patient is non-diabetic. So that is a immunocompromised patient. In immunocompromised patient beta, there is a high risk of fungal infection, and that life-threatening fungal infection which can happen in these patients is nothing else but beta mucormycosis. We know mucormycosis is also called as rhino-oculocerebral mucormycosis. Reason: this is an invasive fungal infection which is not only limited to the nose, it can also involve the orbits and even the cranial cavity or the brain of the patient. So it is called as rhino-oculocerebral mucormycosis beta. Here, as it is an angio-invasive fungus beta, so it will damage the blood vessels, leading to ischemic necrosis and formation of a black eschar beta. So there is this kind of a black eschar which is going to form beta. Okay? If you give definitely बच्चे nebulization of steroids in the patient, then the patient may develop mucormycosis starting from the palate, and then you are able to see beta blackish spots on the palate of the patient. Okay? So either there will be a blackish eschar around the nose, eyes, or there will be a blackish spots on the palate. The patient will have necrosis of the palate leading to loosening of teeth as well beta. Apart from that, initial stages में it will always present to you with beta redness. तो याद रखना, mucormycosis is not always black. In the start, as there will be inflammation, it will appear red beta. Okay? So there will be reddening which is seen beta. Sometimes when the mucormycosis extends to the orbit, the patient will also develop an orbital cellulitis beta. Clear? That is what is important. If they ask you बच्चे that most common cause of mucormycosis will be, याद रखना, the most common cause of mucormycosis, if they ask you, answer is nothing else but rhizopus followed by mucor. The most common cause of mucormycosis is not mucor, it is rhizopus beta. That has to be remembered. Clear? In this condition, if they ask you what is the first investigation to be done, the first investigation to be done in patients of mucormycosis is always an MRI head. Reason: MRI head will be done in a case of mucormycosis just to rule out any cerebral involvement or brain involvement. This was a previous year NEET PG question. So to rule out the brain involvement beta, the first line investigation to be done is always an MRI head. Bache. That was a previous year question. Then I can send a nasopharyngeal swab for mucor also beta. Then you can definitely send a nasopharyngeal swab for mucor. Okay? But apart from that beta, if they ask you which is the best investigation to confirm the diagnosis, the best investigation basically beta to confirm the diagnosis is nothing else but the gold standard of the best investigation to confirm the diagnosis will be biopsy with a histopathological examination. I told you that biopsy along with the histopathological examination has to be the best investigation to confirm the diagnosis. Answer has to be option B for this question. The confirmation of diagnosis can only be done beta after biopsy with histopath. Reason is nasopharyngeal swabs for mucus are not always positive. As the nasopharyngeal swabs will not always be positive beta, that's the reason the best in confirmatory diagnosis will be done by biopsy beta. It is not always practical, but it is usually done. Next important, if they ask you, beta glucan assay can be done for fungal infections, but not a best investigation to be done. Clear? If they ask you definitely beta in this patient, what should be the treatment? So we know beta treatment के लिए the first line is a medical management. What is the drug of choice? The drug of choice in patients of mucormycosis is amphotericin B, fluconazole, liposomal amphotericin B. What is the drug of choice in cases of mucormycosis? Amphotericin B, fluconazole, or liposomal amphotericin B? The drug of choice in patients of mucormycosis is always LAM beta. What is LAM? LAM is nothing else but liposomal amphotericin B, because the conventional amphotericin B is highly nephrotoxic. Therefore, the LAM or liposomal amphotericin B has to be the drug of choice. Treatment of choice, we have to remove all the dead necrotic material. A removal of dead necrotic material is known as debridement beta. A removal of dead necrotic material is known as debridement. Now plus minus, if in case there is the orbital involvement, if there is an orbital involvement, I have to remove the orbit. Removal of orbit is known as bolo. If there is an orbital involvement in patients of mucormycosis, I also need to remove the orbit of the patient, and removal of orbit is known as anybody. Removal of orbit matlab removal of the eyeball along with the extraocular muscles and the orbital bones. Removal of orbit will be called as not an enucleation. Not at all an enucleation. A removal of orbit is known as anybody. What is removal of orbit known as? Removal of orbit, very good. It is known as exenteration. ठीक है, तो removal of the orbit which is there, it is known as an exenteration. तो plus minus exenteration has to be done. Enucleation is only removal of the eyeball. ठीक है, तो exenteration is the removal of the orbit. That is important to remember. Clear? तो plus minus exenteration has to be done. याद रखने का. Next is question number 24 बेटा. Here there is a question which says a patient came to the OPD with complaints of erythematous neck swelling above the clavicle. ठीक है, तो there is a erythematous neck swelling in the supraclavicular region as shown below. The swelling was tender beta. The swelling was tender and pulsatile on examination. Okay, what will be the next line of management for this region? What will be the next line of management for this region? Follow. What should be done in this condition? What is the likely diagnosis beta? What is the likely diagnosis? We know the patient is having erythematous neck swelling beta above the clavicle. The swelling was painful or tender and pulsatile. When the swelling is going to be pulsatile beta in this neck region, we know it is nothing else but a vascular tumor beta. Whenever there is a swelling which is pulsatile, it is a vascular mass or a vascular tumor which is, okay? And that vascular tumor which is there beta, it may be arising from the carotid body. It could be a chemodectoma, right? It could be a vascular tumor beta arising from the carotid bodies, which it could be a chemodectoma. So pulsatile tumor basically arising from the carotid bodies beta, okay, is going to be a vascular tumor like a chemodectoma beta. What should definitely be the next line of management beta? Next line of management. Next line of management. A patient comes to you with a neck swelling which seems to be pulsatile. That is a case of a vascular tumor or a chemodectoma. Bolo. Query, it is chemodectoma. We have to confirm that whether it is a chemodectoma or not. So what has to be the next line of management? To confirm that first, what should be the next step? We know one thing is absolutely contraindicated, and that is needle biopsy. As it is a vascular tumor that we are suspecting, needle biopsy is absolutely contraindicated. Option C is also gone. Reason is oral antibiotics for 7 days will be given if you are suspecting any cervical lymphadenopathy. If there was a cervical lymphadenitis or infection of the cervical lymph node, then I would have given oral antibiotics for 7 days. But it is pulsatile in nature. Pulsatile swelling cannot be a cervical lymphadenopathy. Clear about? So that is important. So now either it is option A, that is ultrasound Doppler neck, or it is option D, CT angiography. Next line agar पूछेंगे, yes, next line of management has to be option A, that is ultrasound Doppler neck. Right now we know that neck vessels are superficial beta, and for those superficial I can go for a color Doppler beta. Okay, so we know that investigation of choice for the central vessels of the body, I've told you that a multiple number of times. Investigation of choice for peripheral vessel is a duplex scan or a Doppler, but investigation of central vessels is always a CT angiography or MR angiography. ठीक है, तो इसीलिए बेटा investigation of choice will always be a CT angiography. But यहाँ पे उन्होंने next line पूछा है. As they have asked you a next line beta, so first we will do a color Doppler or ultrasound Doppler beta because it is in the neck. If it would have been in the thorax, then I would have not gone for ultrasound Doppler. But as it is in the neck beta, I can superficially investigate it with the help of ultrasound or color Doppler, which is non-invasive technique, right? So first go for ultrasound Doppler neck. If you are able to see any vascular tumor, to further confirm it, you can go for a CT angiography. And once you have confirmed it beta, you should go for a surgical excision. So yaad rakhna, the treatment in patients of chemodectoma, which usually arises from the carotid bifurcation, is nothing else but a surgical excision beta. You have to be very careful while excising a vascular tumor like a chemodectoma. Clear? So that is what is important. Abdomen mein hota, to I would have directly gone for CT angio. Then no need of ultrasound Doppler. Ultrasound I would have done. Reason is abdomen mein hai, I would do definitely an ultrasound abdomen first, not an ultrasound Doppler, but an ultrasound abdomen first. And if that suggests that it is a vascular tumor, so to confirm I would go for CT angio always. Clear? Next important question, number 25. What is the significance of the below given line in the image? The line that has been given to you beta in this image. The significance of the given line in the image is what? Now here you are able to see beta, the line that has been given in the image is nothing else but an imaginary line which has been marked beta between the medial canthus of the eye and the angle of mandible. This imaginary line which is drawn between the medial canthus of eye and the angle of mandible beta is classically known as the, which line? It is classically known as the Ongren's line. Very good. So it is known as the Ongren's line beta. Now if I talk about the Ongren's line, please remember that Ongren's line is used for what? Ongren's line can tell us whether the patient's prognosis in a case of maxillary sinus carcinoma will be good or bad basically. Barabar? The answer has to be option B beta. It is used for prognostic evaluation. It is used for prognostic evaluation of carcinoma of maxillary sinus. So whenever a person is going to have a maxillary sinus carcinoma and we want to see whether the prognosis will be good or bad, I am going to use the Ongren's line. If there is a cancer above the Ongren's line beta, then it will cause an early orbital involvement, and due to that, the patient's prognosis is going to be bad or poor beta. Clear? So whenever the cancer is above the Ongrens line, bache, definitely there will be an early orbital involvement leading to a poor prognosis of the patient. Clear? If I talk about maxillary sinus carcinoma, beta, we know maxillary sinus is the most common paranasal sinus where cancer is going to be seen. So maxillary sinus carcinoma, if I talk about, it could be both types beta. Either it could be a maxillary sinus carcinoma, either it could be a adenocarcinoma or it could be a squamous cell carcinoma. If I talk about adenocarcinoma of maxillary sinus happens due to exposure to hardwood or furniture dust. When a person is exposed to a hardwood dust or a furniture dust, that causes an adenocarcinoma of maxillary sinus. But whenever a person is exposed to nothing else but nickel beta, so nickel exposure is actually going to increase the risk of squamous cell carcinoma in the maxillary sinus. Hopefully clear to all of you now. That is important to be remembered beta. Clear? Maxillary sinus carcinoma mein biopsy is not recommended beta because it is very difficult to take a biopsy. So investigation of choice in maxillary sinus carcinoma is CCT. Patient of maxillary sinus carcinoma will come to you with a cheek swelling along with anesthesia of cheek beta, along with weight loss, okay, and other orbital involvement like features. So CCT scan has to be done beta, CCT paranasal sinuses, and on that you are able to see definitely beta a cancer which is growing. Important is once you have confirmed the diagnosis beta, then you should definitely go for treatment. Okay, so treatment ke liye beta we know we have to use this approach. What is this approach called as? This approach that you are able to see beta here, as the cancer is inside the maxillary sinus and maxillary sinus is within the maxillary bone, I have to remove the maxillary bone beta plus minus orbital removal. That is, if in case the orbit is involved, then only I am going to remove the orbit beta. Okay, the maxilla, upper lip and the orbit may be removed. This surgery is known as a total maxillectomy. In maxillary sinus carcinoma, when I do a total maxillectomy beta, it is done with the help of an approach called as the Weber-Ferguson approach. So total maxillectomy is done with the help of a Weber-Ferguson approach beta. So Weber-Ferguson approach is used for total maxillectomy in this patient. Will there be nerve involvement? Yes, obviously there can be nerve involvement. There will be involvement of the infraorbital nerve, and that is the reason the patient has anesthesia of cheek. The patient has anesthesia of cheek basically. Hopefully clear to all of you now. That is what is important. Okay, the approach of maxillectomy in maxillary sinus carcinoma is Weber-Ferguson approach, not Ongrens line. Clear? So that is important. Next is question number 26 beta. Another important PYQ from NEET. Which among the following is not a contraindication of cochlear implant surgery? Which among the following is not a contraindication for a cochlear implant surgery? Matlab, in which among the following conditions a cochlear implant surgery can be done? In which among the following conditions a cochlear implant surgery can be done is the question. I hope all of you are quite aware beta that cochlear implant which is there beta, it is always done whenever the patient is going to have a bilateral profound sensory neural hearing loss, whenever the inner ear or the eighth nerve of the whenever the inner ear of the patient or the cochlea of the patient is damaged. Okay, so bilateral profound sensory neural hearing loss may we have to do a cochlear implant surgery. That is one thing. Okay, what is the important feature? That the eighth nerve of the patient should be absolutely normal. The eighth nerve of the patient in cochlear implant surgery should absolutely be normal. Reason is, in case if the eighth nerve of the patient is not normal, cochlear implant surgery is not going to be useful. Matlab, in a patient of acoustic neuroma, cochlear implant surgery is not useful beta. Reason, in those conditions, as there is acoustic neuroma, the eighth nerve is damaged, and that's the reason cochlear implant surgery is not going to be useful. Clear about? याद रखना, bilateral profound SNHL but 8 nerve normal, in those conditions only a cochlear implant surgery should be done. Now here they have given you some congenital anomalies beta of the inner ear. So these are the congenital anomalies of the labyrinth. Okay, now they are asking you which among the following is not a contraindication. Matlab, in which among the following conditions you can perform a cochlear implant surgery. Now I hope all of you are quite aware. I have discussed this. What are these kind of inner ear anomalies or labyrinthine anomalies? The first one is Montanus dysplasia. What is Montanus dysplasia? Montanus dysplasia is nothing else but beta, when there is an incomplete development of inner ear. Whenever there is an incomplete development of inner ear or an abnormal development of inner ear, that is what is called as Montanus dysplasia. So incomplete development of inner ear is known as an Montanus dysplasia. Next, Michael's aplasia is what? Michael's aplasia is complete absence of inner ear. I have told you that whenever there is a complete absence of inner ear, that is called as a Michael's aplasia. Next, Skibi's dysplasia is what? Skibi's dysplasia or Skibi's aplasia will be a cochleosaccular aplasia. So whenever the cochlea and the saccule are not formed, so cochleosaccular aplasia which is there, whenever the cochlea and the saccule are not going to be formed, That condition is known as Skiby's dysplasia or Skiby's aplasia. Alexander dysplasia or Alexander aplasia is what? Alexander dysplasia or Alexander aplasia matlab membranous cochlea is not formed. We know the membranous cochlea is the main structure beta which will be responsible for all the function. The membranous inner ear is more important, right? The membranous cochlea itself is not formed, that is membranous cochlear aplasia. I've told this to you, I've discussed this with you properly. Follow. Incomplete development of inner ear. Complete absence of inner ear, cochleosaccular aplasia or membranous cochlear aplasia. In which among the conditions you can use a cochlear implant? In which among the following conditions you can use a cochlear implant surgery? You can actually use a cochlear implant. In which among the following cases? मुझे बताओ, cochlear implant surgery में the electrode is going to be placed inside the cochlea. Yes, in cochlear implant surgery we know that electrode will be placed inside the cochlea, and it will only be possible if cochlea is present in the patient. Okay, in all the other conditions cochlea itself is not there na bhai. In all the three conditions there is no cochlea itself. Option E says Alexander aplasia, membranous cochlea is not present over here. So where are you going to place it? Skiby's aplasia, complete it is a cochleosaccular aplasia. Cochlea and sacule both are absent. So where are we going to place the electrode? Michael's aplasia, complete absence of inner ear. Neither cochlea is there, nor utricle and sacule, nor semicircular canal. No part of the inner ear has been found. The answer has to be option A, that is Mondinus aplasia or Mondinus dysplasia. Reason, Mondinus dysplasia is only an incomplete development. So here cochlea is still present. Okay, it is not properly developed, but it is still present. In all other conditions, cochlea itself is not there. Clear है? That's the reason only Mondinus dysplasia is the condition जहाँ पे a cochlear implant surgery can be done. In all other conditions, no cochlear implant surgery would be done. In all other conditions, only a auditory brainstem implant will be required. Clear है? That is important. Next is a picture of nothing else but what is this hearing aid called as? Bolo. What is the name of this hearing aid? I am going to fix a titanium screw bit onto the bone, and on that screw I am going to fix the hearing aid beta. This hearing aid is generally used whenever my patient is having no pinna, that is anosia beta, or whenever my patient is having a very small and underdeveloped pinna called as microtia, or my patient's external auditory canal is not formed, that is EAC atresia, or it is extremely narrow, that is EAC stenosis. So EAC atresia, EAC stenosis, or whenever a person is having a chronic ear discharge, whenever there is a chronic ear discharge, in those conditions, this hearing aid is classically known as BAHA. Now when I say BAHA, BAHA means bone anchored hearing aid beta. This is a classical picture of BAHA, bone anchored hearing aid. It is used in all these conditions. Next, this is the commonest hearing aid that we use beta. This is the most common type of hearing aid that we use, and the most common hearing aid that we use nowadays is nothing else but the BTE. What is BTE? Behind the ear hearing aid. So this is nothing else but the most common type of hearing aid that we use beta, that is the behind the ear hearing aid beta. So behind the ear hearing aid is the most common type of hearing aid. Anybody let me know in the chat box from PSM. Hearing aid is which type of prevention? Primordial, primary, secondary or tertiary? Hearing aid will come under which type of prevention? Let me know in the chat box. Okay, this is actually going to be beta, the cochlear implant. Okay, so here this is the cochlear implant ka picture. If I talk about cochlear implant surgery, I've told you it is done in patients of bilateral profound sensory neural hearing loss beta. Bilateral profound sensory neural hearing loss when there is more than 90 decibels of hearing loss. Condition is 8 nerve should be absolutely normal, otherwise there will be no use of stimulating the cochlea beta if the 8 nerve itself is damaged. Isliye it is important that the 8 nerve should be normal. Here in cases of cochlear implant surgery beta, we know that the electrode should be placed within scalar tympani of the cochlea. So within the scalar tympani of cochlea via the round window. Within the scalar tympani of cochlea via the round window beta, we have to place the electrode. That is what is important to be remembered. And this electrode will stimulate the cochlea. Clear about that is important. Very good. Hearing aid are always an example of a tertiary level of prevention because they only amplify the sound. They do not correct your hearing beta, and therefore they help in limiting your disability. So they are an example of tertiary level of prevention. They do not treat. They only help in limiting the disability. They are an example of tertiary level of prevention. Next important, if I talk about this picture over here, what is seen in this picture? Here you are able to see a implant or the electrode is placed inside the brainstem area. Where exactly? So here in this condition beta, the electrode will be placed in the lateral recess of fourth ventricle. As you are able to see, here the electrode is placed in the lateral recess of fourth ventricle, and this fourth ventricle is located in the brainstem area. So this is nothing else but a picture of ABI, that is auditory brainstem implant. Please tell me, we know that auditory brainstem implant beta is usually done in which condition? तो हमें पता है auditory brainstem implant में electrode is directly placed in the brainstem area beta, which will directly stimulate the auditory pathway of the patient. Why? Because in this condition beta, the 8 nerve will be damaged. So auditory brainstem implant is done in all those conditions where a patient comes to you with a bilateral profound sensory neural hearing loss, but whenever the eighth nerve has been damaged beta, like in patients of neurofibromatosis type 2 or a bilateral acoustic neuroma. We know NF2 patients में there is a bilateral acoustic neuroma, so both the sided eighth nerve has been damaged. इसीलिए cochlear implant surgery is not going to be useful. In those patients we have to go for auditory brainstem implant beta. Important question, auditory brainstem implant में it is actually going to stimulate beta. Please tell me beta. Post surgery definitely you can go for cochlear implant, but condition being that the eighth nerve function should be normal. You have to check that hearing of the patient first. Important is बेटा याद रखना, post surgery most of the conditions में you won't even need a hearing aid. अगर तुमने ट्यूमर ही ठीक कर दिया तो hearing aid क्यों जरूरत है तुम्हें? That is important. If I talk about beta auditory brainstem implant में it stimulates which part of the auditory pathway? Auditory brainstem implant में it stimulates which part of the auditory pathway? Auditory pathway is remembered by the mnemonic E. coli mana. So we know eighth nerve of the patient is damaged, so it stimulates the cochlear nucleus beta. Okay, it stimulates the cochlear nucleus which is located in the brainstem area. Hopefully clear to all of you now. Very good. Yes. Chalo. Next is question number 27 beta. Very classical and easy question. 35-year-old lady, while cleaning her ear beta with the help of a hairpin, she has accidentally damaged her eardrum. So eardrum is nothing else but your tympanic membrane. So here accidentally the eardrum or the tympanic membrane has been damaged and it got perforated beta. As it has got perforated due to the hairpin, so it is a case of a traumatic tympanic membrane perforation. So here it is a case of a traumatic tympanic membrane perforation. Due to that, the patient may have some pain. Along with that, the patient may have some mild conductive hearing loss. What is the best management beta for a traumatic tympanic membrane perforation or a traumatic eardrum perforation? We know the best management in this condition is nothing else but option C, which is that is reassurance. Okay? So reassurance has to be done. Why? Because we know traumatic tympanic membrane perforation is self-limiting beta, right? It is actually going to be self-limiting. It will actually heal within a span of 3 to 6 months beta. Within a span of 3 to 6 months, this perforation is going to heal automatically beta. You don't need any kind of treatment. So just reassure the patient. In case even after 6 months beta, the perforation doesn't heal. So even after 6 months, if the perforation doesn't heal, then we can go for a repair beta, and that repair will be called as a myringoplasty. So even after 6 months when the perforation doesn't heal, then we go for myringoplasty. Yaad rakhna, only traumatic tympanic membrane perforations can heal automatically beta, and therefore you can prescribe reassurance. But if it is a case of an infective tympanic membrane perforation, infective perforations do not heal on their own. For them always we have to go for a myringoplasty beta. We cannot reassure the patient. Clear? Antibiotic ear drops, it is not an infection. Myringotomy, no, here there is no fluid or pus collection that we are doing a myringotomy. Okay, so that is important. Next, question number 28 beta. Here they are asking you that a patient was suffering from a peritonsillar abscess. We have seen already peritonsillar abscess means quinsy beta. The patient was suffering from quinsy and he was experiencing throat pain beta with a referred otalgia. So whenever a person is having tonsillitis or a peritonsillar abscess, okay, or a long styloid process, patient may have definitely irritation of a nerve beta in the tonsillar bed, and due to that the patient will also have a referred earache or otalgia. Which among the following nerve beta is likely responsible for this condition? Patient is having a throat pain beta along with a referred otalgia. So which among the following nerve is likely responsible for this problem? Very good. So I hope all of you are quite aware beta that if you see, this is the tonsillar bed bache. This is the palatine tonsil. This green one is the tonsillar capsule. This yellow space is the peritonsillar space, and in that peritonsillar space there is pus collection called as peritonsillar abscess or quinsy beta. And here definitely we have a nerve called as paratonsillar vein, which is the most common vessel to bleed during tonsillectomy. Now, then we have the muscle which forms the bed of tonsil. That muscle which forms the bed of tonsil is superior constrictor muscle beta. Yaad rakhna. The inner fascia of superior constrictor is called as the pharyngobasilar fascia, whereas the outer fascia is called as the buccopharyngeal fascia. In the recent FMGE exam, they have asked you the inner or the outer fascia. Okay, so pharyngobasilar is the inner one, outer one is going to be the buccopharyngeal fascia. Now, the space beyond the superior constrictor muscle is called as the parapharyngeal space, and here if there is pus collection, that is the parapharyngeal abscess. Important is, in the bed of tonsil you are able to see there is a special nerve called as the ninth cranial nerve, the Jacobson's nerve. Now whenever the person will have tonsillitis, whenever there will be tonsillectomy surgery, okay, or whenever there will be a styalgia, that is Eagle syndrome, or even a peritonsillar abscess like quinsy, there can be irritation of the glossopharyngeal nerve in the bed of tonsil. We know the glossopharyngeal nerve does not only innervate the throat beta, it also gives one of the branches beta to the middle ear, and the branch of the glossopharyngeal nerve which supplies the middle ear is known as option D, that is Jacobson's nerve. So Jacobson's nerve is a branch of the glossopharyngeal nerve or the ninth cranial nerve. This supplies the middle ear. So whenever the glossopharyngeal nerve is irritated within the bed of tonsil, the patient's Jacobson's nerve is also irritated, and that is the reason why the patient is going to have referred otalgia beta. This is the reason why the patient has referred otalgia. So either they will give glossopharyngeal nerve in the option or they will give Jacobson's nerve in the option. Be aware of that. Clear about? These are the important points that you need to keep in mind beta. Yaad rakhna, referred otalgia which is there. It is usually seen in conditions like what? As I've told you, as I've just enumerated, referred otalgia or a referred earache. It is usually seen in conditions wherever there is irritation of glossopharyngeal nerve. Conditions like tonsillitis, a surgery like tonsillectomy, where by mistake we can injure it. Third, it could be a styalgia, that is Eagle syndrome. Or fourth, it could be a case of quinsy, that is a peritonsillar abscess. Hopefully clear to all of you now. That is important. Please tell me beta, Arnold's nerve, also called as the Eiderman's nerve. If this nerve is irritated, we know Arnold's nerve or the Eiderman's nerve is going to supply the floor of the external auditory canal. So we know that Arnold's or the Eiderman's nerve, when it is irritated, whenever we do ear syringing beta in a downward manner. So whenever ear syringing is done in the antero-inferior direction, the Arnold's nerve is irritated beta, and Arnold's nerve is a branch of vagus nerve. So jab bhi the Arnold's or the vagus nerve gets irritated, the patient will have definitely beta two problems. One, as the vagus nerve is irritated, the patient will have a cuff reflex, and second, as the vagus nerve will be irritated beta, the patient is also going to have, we know vagus nerve is a parasympathetic nerve. So suddenly the patient's heart rate and the blood pressure are going to decrease beta. Due to that, there is a sudden decrease in the blood supply to the brain, causing a vasovagal syncope. So either the patient is going to have a cuff reflex beta or a vasovagal syncope whenever you do ear syringing in antero-inferior direction and irritate the Arnold's nerve beta. Okay, that is what is important. Clear about? Next is nerve of Würzburg. So we know nerve of Würzburg is a sensory division of the facial nerve which supplies the postero-superior part of external auditory canal. Now, whenever the nerve of Würzburg is going to be damaged, it is usually damaged in acoustic neuroma. In a patient of acoustic neuroma beta, when the tumor grows, we know initially it causes damage to the, more commonly it causes damage to the fifth nerve, but apart from fifth nerve, it can also cause damage to the sensory division of facial nerve called as nerve of Würzburg. And whenever this nerve is damaged beta, patient will have loss of sensations in the postero-superior part of external auditory canal, and that is classically known as the Hitzelberger sign. So in patients of acoustic neuroma, there is a classical Hitzelberger sign, that is loss of sensations in the postero-superior part of external auditory canal due to involvement or damage of nerve of Würzburg. Median nerve, it is the main nerve beta responsible for causing vasomotor rhinitis. So vasomotor rhinitis happens due to irritation of median nerve. So we have to do a median nervectomy in patients of vasomotor rhinitis. Hopefully clear. Next, question number 29. Sarkari question. A patient underwent a superficial parotidectomy beta or a pleomorphic adenoma. We know that pleomorphic adenoma is the most common benign tumor of the parotid gland or salivary glands. The most common benign tumor of parotid gland is the pleomorphic adenoma, for which the patient has undergone a surgery called a superficial parotidectomy. Now, a few months later, the patient complains of facial sweating and skin flushing beta. So there is sweating and redness over the face beta whenever he eats food. So whenever the person is going to eat food, especially spicy food, the person is going to have sweating and flushing over the face. What is the likely diagnosis, anybody? On eating food, if the person is going to have sweating and flushing over the face beta, okay, it is because a nerve was injured beta during the superficial parotidectomy surgery, and due to that, what was happening? The nerve has regenerated, but now the nerve by mistake is supplying the blood vessels and the sweat glands in the skin beta. And as it supplies the blood vessels or sweat glands and skin, तो क्या होगा? Definitely beta, whenever the person will eat food, he will come to you with complaints of facial sweating and skin flushing. Whenever he eats food, these are the problems that will happen. This is the classical diagnosis of which condition? Yes, it is a classical diagnosis of Fraser syndrome beta. The classical diagnosis of this patient is the case of Fraser syndrome. And whenever I talk about Fraser syndrome, please tell me, Fraser syndrome happens due to injury or aberrant regeneration of which nerve? Fraser syndrome happens due to injury and aberrant regeneration of which nerve basically? Let me know in the chat box. Injury or aberrant regeneration to which nerve is actually going to cause Fraser syndrome? Follow. Very good. The answer has to be option C beta. That is nothing else but the auriculotemporal nerve. So whenever the auriculotemporal nerve is injured and it has got abnormally regenerated, the patient is going to develop phrase syndrome. Whenever the patient will eat food, there will be facial sweating and flushing beta. Chorda tympani and this facial phrase syndrome is also called as gustatory sweating. Chorda tympani nerve, if it is injured and regenerated, then the patient is actually going to have tears beta. Matlab, whenever the person will eat food, the person is actually going to have tears coming from the eyes beta. So whenever the person eats food, there is tearing from the eyes called as crocodile tears or gustatory lacrimation. So crocodile tears or gustatory lacrimation happens whenever there is an injury and aberrant regeneration of the chorda tympani nerve beta. Greater auricular nerve, if it is damaged, then the patient is going to have anesthesia over the angle of jaw. Okay, so we know after the surgery, if the patient is having anesthesia over the angle of mandible or over the angle of jaw beta over here, that means the greater auricular nerve of the patient has been injured. Clear about median nerve? I have told you it is responsible for vasomotor rhinitis. Clear? Treatment and phrase syndrome, I have told you beta, these abnormal fibers of the auriculotemporal nerve which have regenerated and which are supplying the sweat glands and the blood vessels in the skin, we have to just give an injection of botulinum toxin over there and we have to kill these abnormal fibers beta. Clear? Next, question number 30, which we are having a patient who is suffering from earache beta. Okay, along with that the patient also experiences retroauricular pain. Okay, with profuse mucopurulent ear discharge beta. So mucopurulent pulsatile otorrhea. Otorrhea means ear discharge. Okay, so patient is having a profuse mucopurulent pulsatile otorrhea beta. On cleaning, pus fills up immediately. We know this is a classical sign beta called as reservoir sign. So whenever you clean the pus beta, it will fill up immediately as if there is a reservoir of pus in the patient beta. There is a classical reservoir sign which will be seen in this patient. Okay. Examination finding has been given below. What is the best management option in the patient? Bolo. What is seen on the examination? What is the sign called as? Let me know in the chat box. What is this classical sign which is seen called as? Behind the ear, you are able to see a red, shiny mastoid surface beta. What is this classical feature? What is this classical sign? Red, shiny mastoid surface beta. What is the classical sign? Red, shiny mastoid surface. Yes, it is known as ironing of mastoid beta. So it is the classical feature known as ironing of mastoid surface, and we know ironing of mastoid surface which is there beta, it is due to inflammation or infection of the mastoid hair cells. Ironing of mastoid definitely happens whenever there is an infection or inflammation of the mastoid hair cells beta. That has to be remembered. Clear? So reservoir sign, ironing of the mastoid, both of these are very classical features of which condition? We know the diagnosis of the case is nothing else but all of you are correct. It is a case of acute mastoiditis beta. So जब भी patient में there will be an acute mastoiditis बच्चे, that is infection of the mastoid hair cell. We know acute mastoiditis can occur as a complication of ASOM or CSOM. मतलब the patient was having otitis media or a middle ear infection from where the infection has spread posteriorly बच्चे to the mastoid hair cells, and due to that the patient has developed acute mastoiditis. And due to acute mastoiditis बच्चे, the patient is having these features like reservoir sign, ironing of mastoid surface, or earache, retroauricular pain, mastoid tenderness. All of these are the classical features. Clear about? If they ask you what should be the best management option, we know for the acute mastoiditis ka case beta, the treatment option is nothing else but option C, which is that is Schwartz operation, also called as cortical mastoidectomy beta. We have to go for a Schwartz operation, also called as a cortical mastoidectomy. Anybody? Schwartz sign is seen in which condition? Schwartz operation is done for acute mastoiditis, that's fine, but let me know Schwartz sign on the tympanic membrane. It is usually seen in which condition? Let me know that in the chat box. We know modified radical mastoidectomy beta, it is done for all other complications of unsafe CSM. Whenever a person is going to have an unsafe CSM or an articoantral CSM beta or all other complications, then we can go for a modified radical mastoidectomy, also called as tympanomastoid exploration. Type 3 tympanoplasty is done for safe CSM. I have already told you, whenever the person will have a safe CSM, we go for a type 3 tympanoplasty. That is, we have to go for a myringostapediopexy beta after removal of the eroded malleus and incus. Clear? Myringotomy with pus drainage is done in ASOM beta. Whenever there is a patient of ASOM beta with a lot of pus, okay, whenever there is a patient of ASOM with bulging out tympanic membrane due to pus beta, in those conditions, we have to go for incision on the tympanic membrane to drain the pus. That is called as myringotomy with pus drainage beta. Yeah? Yes, very good. We know Schwartz sign is a feature of early stages of autosclerosis. So early stages of autosclerosis mein there is a flamingo pink appearance on tympanic membrane, and that flamingo pink appearance on tympanic membrane is classically called as beta, nothing else but Schwartz sign. Clear? But next is now what is the landmark beta? We know in acute mastoiditis, when we go for a cortical mastoidectomy or a Schwartz operation, the first step in the Schwartz operation is to find the mastoid antrum, which is the largest and the most constant mastoid hair cell. What is the surgical landmark for the mastoid antrum? Let me know in the chat box. The surgical landmark for a mastoid antrum is going to be, yes, very good. Early stages of autosclerosis, whenever the Schwartz sign is positive, the treatment is not a surgery like stepidotomy or stapedectomy. It is definitely oral sodium fluoride to stabilize the disease. Yes, so Mac-Evans triangle beta. For mastoid antrum, the surgical landmark has to be a suprameatal triangle called as the Mac-Evans triangle. Which question number 31, if they ask you now. A patient is presented to the emergency room with sudden onset right-sided facial weakness. On the right side of the face, he is having weakness beta. So there is a sudden onset right-sided facial weakness. There is tingling sensation also in the face along with drooping of mouth beta on the right side. The patient is having drooping of mouth beta on the right side like this. Okay. Along with headache. The patient was advised oral steroids and acyclovir. Okay. But after 3 weeks of therapy beta, but after 3 weeks, patient returns with no improvement. So even after 3 weeks of oral steroid therapy beta, the patient is having no improvement basically. What shall be the next step in the management of the patient? What shall be the next best step? Yes. The provisional diagnosis of the case is nothing else but of Bell's palsy beta. We know whenever the person is going to have a Bell's palsy, that is a 7th cranial nerve or a facial palsy beta, the patient is going to have a right-sided, the patient is going to have a facial weakness beta along with drooping of mouth. So yaad rakhna, Bell's palsy is basically a 7th cranial nerve palsy, but it is a element palsy. Matlab, it is a lower motor neuron facial palsy beta. That was a PYQ. Bell's palsy is not a upper motor neuron facial palsy. Yaad rakhna, all facial palsies are not Bell's palsy. Bell's palsy is only a sudden idiopathic lower motor neuron facial palsy beta. Some cases of Bell's palsy can be due to, beta, HSV infection. What is HSV? That is herpes simplex virus infection. So some cases can be due to HSV, that is herpes simplex virus infection. Okay. Now in this condition beta, we know what will be the feature. First, patient will have loss of wrinkling beta. Please tell me, loss of wrinkling is only a feature of upper motor neuron or lower motor neuron facial palsy? Loss of wrinkling beta will only be a feature of upper motor neuron or a lower motor neuron facial palsy. Let me know in the chat box. Apart from that, patient will have drooping of mouth on the affected side beta. So there is drooping of mouth on the affected side which is seen. Okay, whereas there is deviation of angle of mouth on the normal side. So there is deviation of angle of mouth on the normal side beta. If you see, the person will not be able to close the eye completely on the affected side. Okay, why? Because the orbicularis oculi muscle, which is the facial muscle, that will also be paralyzed. And when the person is not able to close the eye completely beta on the affected side, that is called as lag of thalamus. And that is the reason beta, any kachra or debris can go into the patient's eye. As the eye is always open, the debris can go into patient's eye beta, increasing the risk of exposure keratitis in the patient. Increasing the risk of exposure keratitis. These are the features whenever a patient is going to have facial palsy or a Bell's palsy. Yes, so please remember beta, loss of wrinkling is only a feature of lower motor neuron facial palsy. It is only a feature of lower motor neuron facial palsy. Yeah, now reason is upper motor neuron damage mein the patient will have increased tone of muscles. That means there will be spastic palsy. But in lower motor neuron damage, the patient will always have decreased tone of muscles, that is flaccid palsy. And due to that, there will be loss of wrinkling. Upper motor neuron facial palsy mein there is no loss of wrinkling. Yaad rakhna. That is important. Clear? Now we know in treatment of Bell's palsy beta, the treatment is nothing else but oral steroids. The drug of choice is going to be oral steroids because majority cases are idiopathic. Few cases which are due to HSV infection, over there we can give acyclovir. But acyclovir is only effective if you have started it within 72 hours. Acyclovir is only effective if you have started it within 72 hours. Oral steroids in patients of facial palsy or Bell's palsy should be recommended for 3 weeks. Here patient has been taking 3 weeks of oral steroid therapy, but still the patient is not having improvement. What is going to be the treatment? Patient is not having improvement. What is going to be the next step? The next best step has to be, even after 3 weeks of steroid therapy, when the person has no improvement, the next step has to be, yes, the next step has to be nothing else but we have to do a nerve conduction study, and that nerve conduction study is an electrophysiological nerve testing. Why? Electrophysiological nerve testing will tell us that whether the nerve fibers of the patient have been damaged or not. If the nerve fibers of the patient have been damaged beta, then only we will go for a surgery. Okay? So please remember, electrophysiological nerve testing has to be done, and if the nerve fibers have been damaged, then we go for a surgery. So if they ask you treatment, the definitive treatment if the nerve fibers are damaged, it is surgical decompression or surgical repair of the nerve. But it is only done once you find that definitely the nerve fibers have been damaged. So please remember, it is going to be electrophysiological nerve testing. That has to be the next best step. Clear about? That is important. Next important is question number 32 beta. Here there is a patient who comes to the ENT OPD with complaints of earache along with a chronic foul smelling ear discharge and has been diagnosed as a case of unsafe CSOM beta. Now the person was diagnosed with unsafe CSOM, do remember that. On examination, the fistula test of the patient came out to be positive. Now, we know that the patient is already a case of unsafe CSOM where the walls of the middle ear will be damaged, and as the walls of the middle ear will be damaged, the patient may develop a complication known as labyrinthine fistula, where there is an abnormal connection with the inner ear or the labyrinth beta, and that condition is known as labyrinthine fistula, and that's the reason why the patient's fistula test came out to be positive. But the patient has refused the treatment beta, and now the patient has come back to us after 3 months. The patient is back to us after 3 months beta, and now on examination the fistula test comes out to be negative. The patient did not take the treatment beta, but still after 3 months beta, the fistula test of the patient is coming out to be negative. What will be the likely finding on pure tone audiometry? Likely finding beta, not on pure tone audiometry, on tuning fork test of this patient. What should be the likely finding on the tuning fork test in this patient? Okay, even on pure tone audiometry beta you can get this finding. Okay, even on pure tone audiometry you can get this finding, but more classically we check it on tuning fork test. Okay, bolo. So we know beta that if the patient was having unsafe CSOM, okay, he has developed a complication, and that complication is nothing else but beta, what? A labyrinthine fistula. And as there was a labyrinthine fistula, that's the reason which the fistula test has come out to be positive. But after 3 months now the fistula test is coming negative even without treatment. What is the reason for that? What is the reason the fistula test is true negative or false negative after 3 months? The fistula test which came out to be negative after 3 months, it was true negative or false negative? ये बताओ पहले, then we will talk about Rene. The fistula test that came out to be negative after 3 months, it was definitely true negative or false negative? The fistula test that came out to be negative after 3 months, it was false negative. Reason? We know the fistula is still present inside the patient's ear beta after 3 months. Okay, still the fistula test is coming out to be negative. So even in presence of fistula, as the test is coming out to be negative, it has to be a false negative fistula test. Why the test is false negative? Reason, in this 3 months time of span beta, what has happened? The middle ear infection beta, as the person did not take the treatment, the middle ear infection has gone into the inner ear, and the inner ear of the labyrinth of the patient is completely damaged. That is, there is a dead inner ear. As there is a dead inner ear beta, that's the reason now the inner ear is not responding, and that is the reason why the patient is having a false negative fistula test. Okay, so even on performing fistula test, the person does not experience vertigo after 3 months. Reason is only because the inner ear has been completely dead and it is not responding at all. Now, whenever there is a dead inner ear beta, we know the patient will have a unilateral severe sensory neural hearing loss. In case of dead inner ear, the patient will have a unilateral severe sensory neural hearing loss beta. So please tell me, in this condition, what is going to be the expected finding? The expected finding beta, remember that. Now, if my patient is having a completely dead inner ear beta, so whenever I check the Rene of the patient, we know that as there is a case of a sensory neural hearing loss beta, we know in a patient of sensory neural hearing loss, normally what the patient should say, doctor sahab, my bone conduction is poor, my air conduction is, my bone conduction is poor, my air conduction is poor, but still my air conduction is better. Matlab, normally in a patient of SNHL beta, he should always say that the Rene is positive. Okay, normally in a case of SNHL or sensory neural hearing loss, he should always say beta the Rene is positive. But in this patient, definitely he will say that the Rene is negative. If there is a dead inner ear na, then your patient will say beta that the Rene is negative. Okay, and Rene negative का मतलब क्या होता है? He will say Rene is negative, मतलब he says that bone conduction is better than air conduction. And why does he say that bone conduction is better than air conduction? Reason is, please remember that when you check for air conduction, that is poor. When you check for bone conduction, he says it is better. Reason, please remember beta, my right sided ear is completely dead beta. But when we check for bone conduction, the vibrations of the sound are not processed in the same cochlea beta. The vibrations will travel throughout the cranial cavity and they will reach the opposite sided normal cochlea. And while bone conduction, these vibrations go to the opposite sided normal cochlea and these sounds are actually heard in the opposite ear. That's the reason the patient feels as if the bone conduction was better. And that's the reason he says that doctors of bone conduction was much better. Easily, the Rene comes out to be negative. But the problem is beta, we know that here the bone conduction was not processed in the same ear. It was processed in the opposite ear. So it is a true negative or a false negative Rene? We know it is a false negative Rene. So whenever a person is going to have a dead inner ear or a unilateral sensory neural hearing loss, okay, due to transcranial transmission of sound and due to processing of sound in the opposite sided normal cochlea, the person says that bone conduction was better than air conduction. Isiliye, it will be a false negative Rene beta. The answer to this question has to be option C. I told you this was a PYQ in your FMGE exam. Exactly same question. Okay, so exactly this question has appeared in the exam. Clear? You have to understand by this that the fistula test is coming out to be negative after 3 months. So it could be a false negative fistula test. That means the infection would have spread into the inner ear till now. And that's the reason definitely the patient will have a false negative Rene as well. Hopefully clear all of you now. Question number 33 beta. It states a patient presents to you with frank bleeding beta. A patient presents to you with frank bleeding from the nose. We know bleeding from nose is nothing else but epistaxis. So patient is having frank bleeding from the nose to the emergency. The bleeding is not controlled by the Trotter's method beta. What should be the next best step? The bleeding is not controlled by Trotter's method. What is the next best step in the treatment of the patient? Let me know in the chat box what should be the next best step in the treatment of this epistaxis in the patient beta. If I talk about epistaxis, we know epistaxis is nothing else but nosebleed beta. There are two types of epistaxis. One is anterior epistaxis, second is posterior epistaxis. We know anterior epistaxis is more common and it more commonly happens in children beta. It is more common and it more commonly happens in children. The most common site to bleed is going to be the little area. Why? The reason is nose picking. As small children are going to do nose picking on nail trauma beta, that nail trauma is going to damage the little area, and that little area is damaged beta, which contains a Kieselbach's plexus, and that Kieselbach's arterial plexus in the little area gets damaged, and therefore the patient starts bleeding. Please tell me which artery does not form a part of the Kieselbach's plexus. Which artery is not a part of the Kieselbach's plexus? Let me know in the chat box. We know Kieselbach's plexus is a network of 4 arteries present inside the little area, which bleeds beta, leading to anterior epistaxis. We know the 4 arteries which form Kieselbach's plexus. One is the sphenopalatine artery, second is the greater palatine artery, third is the superior labial artery, and fourth is the anterior ethmoidal artery. The artery that does not form a part of the Kieselbach's plexus, yes, it is the posterior ethmoidal artery. Shabash. The posterior ethmoidal artery does not form the Kieselbach's plexus. That is important. Which is the artery of epistaxis, anybody? The artery of epistaxis, if they ask you. So please remember the artery of epistaxis that we have beta. It is nothing else but your sphenopalatine artery. हमें पता है sphenopalatine artery is considered as the artery of epistaxis, which is the most common artery to bleed beta in patients of epistaxis. Now we know anterior epistaxis mein, so it is the Kieselbach's plexus or the sphenopalatine artery that bleeds. Anybody? Posterior epistaxis, which usually happens in elderly patients beta due to uncontrolled hypertension, which is the plexus that bleeds. Please tell me beta, posterior epistaxis which happens in elderly patients due to uncontrolled hypertension, which is the plexus that bleeds. What is the plexus that bleeds in posterior epistaxis in elderly patient? Let me know in the chat box. We know whenever a person of epistaxis comes to us, the treatment has to be in a stepwise manner. Yes, very good. Woodruff's plexus is the one beta that bleeds in posterior epistaxis. It is the Woodruff's plexus that bleeds. Clear? Treatment की अगर मैं बात करूँ बेटा, तो please remember treatment में the first step is always, we know best method to control bleeding is always pinch the nostrils. The best method to control bleeding is always pinch the nostrils beta. So we have to definitely pinch the nostrils. That is called as which method? Trotter's method. We know pinching the nostrils, which is there beta. It is the first step in epistaxis and that is known as Trotter's or the Hippocratic method. Clear? This should be done for a span of 5 to 7 minutes and the patient should be in a sitting position with bending. The patient should be sitting position mein, and he should be bending forwards. Next, if this fails beta, then obviously we should go for a chemical cauterization. If this fails, we should go for chemical cauterization. That chemical cauterization beta can be done with the help of AgNO3, that is silver nitrate of phenol. So you can definitely press a cotton swab which is dipped in silver nitrate of phenol beta against the bleeding site. Condition for chemical cauterization is we should know the bleeding site. If you're not able to know the bleeding site, you cannot perform a chemical cauterization because here you have to press the cotton swab against the bleeding site itself, which will coagulate the bleeding vessel. If that fails beta, or if bleeding site is not identified, then we can go for a nasal packing. Either it could be anterior or a posterior or a both. Nasal packing has to be done. In case beta, if nasal packing could not be done, if nasal packing is also failed beta, nasal packing has been tried, it also fails, then which is the first artery to be ligated? If nasal packing fails, so we know beta the first artery to be ligated has to be the most common artery which bleeds, that is artery of epistaxis, and that is nothing else but SPAL, endoscopic sphenopalatine artery ligation. It has to be the endoscopic sphenopalatine artery ligation. If endoscopic sphenopalatine artery ligation also fails, then we have to ligate the parent artery, and the parent artery is nothing else but maxillary artery. Then you should go for a maxillary artery ligation. In case if maxillary artery ligation also fails, then we should ligate the ECA, that is external carotid artery. So external carotid artery or ECA should be ligated. In case beta, if the external carotid artery ligation also fails, in case if the external carotid artery ligation also fails, then what should be ligated next? If ECA ligation also fails, then what should be ligated next? Are you going to ligate IC or CCA? If ECA ligation fails, then yes, very good. So please remember the last option that we have, bache, is nothing else but the ethmoidal artery ligation. Okay, ICA or CCA should never ever be ligated. ICA or CCA should never ever be ligated. ठीक है, सर्जरी चल रही है बेटा, ये पूरी सर्जरी है. ठीक है, so ethmoidal artery ligation is the last step that you have to carry out. Clear about that? Is important to remember. Ethmoidal arteries are the branches of internal carotid artery. So here we have tried pinching the nostrils by Trotter's method, but that has failed. So the next best step has to be nothing else but chemical cauterization. So answer has to be option A, beta. So option A definitely, beta, has to be the next best step, chemical cauterization, beta. Okay, this is the Trotter's method, beta. You can see you have to pinch the nostrils and the patient should breathe via mouth, beta. Okay, this is Trotter's method. The patient should be in sitting position, leaning or bending forwards. This is the Hazelbach's plexus, beta, which is a known cause of an anterior epistaxis, which is okay, whereas this is the Woodruff's plexus, which is present in the choana, and it is a known cause of posterior epistaxis, beta. Clear about? This is the picture of an anterior and a posterior nasal packing. I've told you now, anterior nasal packing can be done with the help of these roller or tape gauge, but nowadays we use PVA, that is polyvinyl arsenide packs. Posterior nasal pack were also done with the help of these gauge pieces. Nowadays we have posterior nasal catheters like these available. Can you see this is a posterior nasal and anterior nasal catheter? You can just inflate the balloons inside these catheters, beta, and they can actually be used in the in the process of nasal packing nowadays. Okay? If you keep the packs for a longer duration of time, then they cause a toxic shock syndrome. You have to replace it after every 24 to 48 hours. Not always they will cause. Clear? Question number 34, if they ask you, which type of joint basically, beta, is present in the below given image? What is the type of joint that you are able to find in the below given image? Anatomy and ENT question together. Bolo. This joint, we know these are the 3 ear ossicles. The 3 ear ossicles that I am able to see. The first one is malleus. The second one in the picture is incus, and the third one is stapes. I hope all of you are quite aware that you know that malleus and incus, which are there, both of them are derivatives of the first pharyngeal arc, beta, whereas stapes is a derivative of second pharyngeal arc. The whole stapes is derived from the second pharyngeal arc. We know the whole stapes is derived from second pharyngeal arc except the foot plate. Foot plate of stapes is a derivative of neuroectoderm. Foot plate of stapes is a derivative of neuroectoderm. Important, if they ask you about the incudo-stapedial joint, anybody, first of all, sorry, the incudo-malleolar joint. The incudo-malleolar joint will be an example of. The incudo-malleolar joint, if they ask you, beta, we know it is an example of saddle or a sellar variety of joint. So we know that the incudo-malleolar joint will be an example of saddle or the sellar variety of joint, whereas the incudo-stapedial joint, will be an example of ball and socket joint. The incudo-stapedial joint will be an example of ball and socket joint. Hopefully that's clear to all of you now. So that is important. तो याद रखना यहाँ पे कौन सा joint दिखाया हुआ है, which is the joint that they have shown over here. सब ने A mark किया है. Please tell me what is the type of joint that you are able to see over here, beta. What is the type of joint? This is nothing else but a joint between the malleus and the incus. So the type of joint in the malleus and incus is nothing else but, beta, option C, that is a saddle or a sellar variety of joint. So answer has to be option C, that is a saddle or the sellar variety of joint. Hopefully that's clear to all of you. That is important. The ball and socket will be the incudo-stapedial joint. This one is the ball and socket joint. Clear? That is important. Condyloid joint and pivot joint are not present in the ear. Hopefully clear to all of you now. याद रखना. We know tympanic membrane is the structure which is derived from all the 3 germ layers, that is endoderm, ectoderm as well as the mesoderm. Okay? Question number 35. Easy question again. We have a 65-year-old patient, beta, that is an elderly patient who comes to the OPD with complaints of an ulcerative lesion, beta, with rolled out margins on the lateral wall of the nose, bache. Histopathological examination has shown this picture after excisional biopsy. So excisional biopsy of that whole lesion was done and a histopath has been done, which has been shown below. What is the most probable diagnosis, beta? Histopath is usually showing you ulcerative lesion, beta. Okay? So there is an ulcerative lesion definitely which on the histopathological examination that you are able to see. Okay? So that is what is important. Bolo. What is the likely diagnosis of the case? Yes. So we know, beta, here the patient is having an ulcerative lesion on the face with rolled out margins. We have discussed rolled out margins are only seen in basal cell carcinoma, that is a BCC. We know BCC is the most common type of skin cancer in face. The most common skin cancer in face is basal cell carcinoma, and commonly it happens on the medial canthus of the eye followed by lateral wall of nose. So medial canthus of eye followed by lateral wall of nose is the common at sites, beta. investigation के लिए you can do an excisional biopsy beta, that is completely remove the lesion and send it for histopath. ठीक है, histopath will definitely show you this kind of a picture beta. If they ask you, the diagnosis has to be a basal cell carcinoma. Treatment, we know beta, treatment for a basal cell carcinoma is nothing else but a wide local excision. So wide local excision is the treatment for a case of a basal cell carcinoma. Rolled out margins or rolled out edges is a classical hint for a BCC. Rolled out edges has to be the classical hint beta. Clear? Melanoma would be a irregular or asymmetrical lesion with changing colors which is continuously evolving beta. Okay, usually on the eyelids. That is a classical case of melanoma. Okay, so this is the classical picture of melanoma. I hope all of you are quite aware about the ABCD of melanoma. Melanoma ka ABCD matlab, it is actually going to be an asymmetrical lesion beta, that has to be remembered. Second important beta, the borders which are there in a melanoma are always going to be uneven or irregular. Borders of melanoma are always going to be uneven or irregular beta. Third important, C, we know the color of the melanoma is going to be changing. Okay, the color of the melanoma is continuously changing from brown to black. Okay, next important beta, D for diameter. We know that melanoma is going to be large in size beta, the diameter is going to be more. And E for evolving, matlab it will continuously keep on growing in size, it will keep on continuously changing color, so that is going to be evolving beta. That is what is important. Okay, this is nothing else but the cutaneous horn beta that you are able to see, and cutaneous horn is another name for anybody. Oh, the cutaneous horn is another name for option 0, seborrheic keratosis or actinic keratosis. Seborrheic keratosis or actinic keratosis. Cutaneous horn is another name for seborrheic keratosis or actinic keratosis. Cutaneous horn, which is there, it will increase the risk of squamous cell carcinoma, but okay, it will increase the risk of squamous cell carcinoma, but it is seborrheic keratosis or actinic keratosis. It is actinic keratosis beta, that is important. Okay, it is an actinic keratosis. Important is, if they ask you, definitely this is a classical picture beta where you are able to see an ulcerative region with rolled out margins, and whenever there is an ulcerative region on the lateral of the nose or in the medial canthus of eye with rolled out margins, that has to be a picture of BCC, that is a basal cell carcinoma beta. Question number 36. Here we are having a cattle breeder beta who presents to us with complaints of nasal blockage due to a reddish mass and a recurrent epistaxis. So reddish mass and recurrent epistaxis will be seen within this patient. Histopathological examination of mass bache reveals the following feature. Okay, it reveals the following feature. What is the most probable cause of this condition? What is the most probable cause of the patient's condition beta? What do you think? Here you are able to see beta histopathological examination. It is actually showing you better what? It is showing you spirules bache. It is going to show you spirules with endospores. These are nothing else but spirules with endospores beta, which are going to be seen on histopath. Okay, that is important to be remembered. We know the person is actually having beta a reddish mass, which can also be described as a mulberry like nasal mass beta, which can actually cause nosebleeds or epistaxis bache. It is usually seen in cattle breeder, okay, who will definitely be using beta the same contaminated water that is also used by animals bache. That's the reason. Okay, so this is a classical case of infection bache, and that infection is due to aquatic protozoa known as rhinosporidiosis. The diagnosis of this case is nothing else but rhinosporidiosis beta, and we know rhinosporidiosis is the infection caused by an aquatic protozoa known as option A, Rhinosporidium sebarii bache. Rhinosporidium sebarii infection happens beta due to contact with dirty water. Important, the patient will come to you with a complaint of a reddish vascular mass beta. That is nothing else but this reddish vascular mass is described as a mulberry like nasal mass. The patient is actually going to have a mulberry like nasal mass beta. Okay, the patient is actually going to have a mulberry like nasal mass definitely, and the patient is going to bleed beta. Okay, mulberry like nasal mass along with epistaxis is the classical complaint in patients of rhinosporidiosis. If they ask you diagnosis ke liye beta, usually we can do a biopsy at times. Okay, usually we do it after remol only, and when you do a histopath, you are able to see this classical presentation of these are the spirules and they contain the endospores of this aquatic protozoa beta. That is a classical histopathological presentation. If they ask you what is going to be the treatment, हमें पता है rhinosporidiosis में the treatment is nothing else but surgical excision of the mass has to be done. We have to do a surgical excision of the mass beta with cauterization of the base, right? Reason is the chance of recurrence is very high, and therefore to prevent the recurrence beta, we have to do a surgical excision of the mass with cauterization of the best beta. Please remember, and followed by that, the drug which is given to prevent recurrence is going to be nothing else but dapsone beta. Okay, the dapsone is only the drug to prevent recurrence. It is not the treatment of choice. Treatment of choice is always a surgical excision with cauterization at the base. Hopefully clear. Next important, if they ask you beta, it is this one. What you are able to see over here, Here we are able to see beta a very irregular nose. Okay, this is actually called as a Hebra nose. We know better that Hebra nose or a tapir nose is going to be the last stage in patients of rhinoscleroma. So rhinoscleroma means the patient will come to us with 3 stages. One is the atrophic stage, second is the granulomatous stage, and third is the fibrotic stage. So fibrotic stage means there is a severe nasal deformity like the Hebra nose or the tapir nose beta. Okay, and in that condition the patient will come to us. We know rhinoscleroma is a bacterial infection of the nose beta, and here the texture of the nose is going to become woody hard. So we can also call it as woody nose. So rhinoscleroma is also known as woody nose, and it is a bacterial infection beta caused by an organism known as Klebsiella rhinoscleromatis. So caused by an bacterial infection beta known as Klebsiella rhinoscleromatis beta. Okay, this is important to remember. So rhinoscleroma or woody nose caused by Klebsiella rhinoscleromatis, which is the condition. We know here the patient will have nodules over the nose beta, and these will be these will undergo fibrosis leading to extremely woody texture beta or hard texture. If they say biopsy of rhinoscleroma is going to show you which classical feature, let me know in the chat box. Biopsy of rhinoscleroma will show you which classical features beta, which cells and which bodies. Biopsy of rhinoscleroma or histopathological examination of rhinoscleroma will show you the classical which bodies beta. Very good. So yaad rakhna, it is going to show you the classical maculus cells along with Russell bodies, which is the maculus cells along with Russell bodies is the classical histopathological feature of rhinoscleroma in the patient. And lastly, if they ask you treatment, we know treatment has to be a combination of antibiotics like streptomycin plus tetracycline. So streptomycin and tetracycline combination should be used in the treatment of rhinoscleroma in the patient. Hopefully clear to all of you now. This is a picture of nothing else but beta where there are wide roomy nasal cavity. A female comes to us beta. A female comes to us with wide nasal cavities beta, and these wide nasal cavities are full of crust. Okay, the patient comes to you with a complaint of wide nasal cavities full of crust. Patient is going to have an excessively foul smell beta. There's an excessively foul smell coming from the patient's nose, and this female who is there beta is going to have a very classical symptom known as merciful anosmia. The patient is going to have a very classical symptom known as merciful anosmia. Matlab, she is emitting foul smell, but she herself is suffering from anosmia beta. Okay, so wide nasal cavities full of crust, foul smell along with merciful anosmia. Yes, it is a classical diagnosis of which condition? Very good. It is a classical diagnosis of condition known as atrophic rhinitis. In atrophic rhinitis, as the turbinates, the nasal terminates undergo atrophy. As the nasal terminates undergo atrophy, therefore there are wide spacious nasal cavities beta, and these wide spacious nasal cavities are going to have excessive dried mucus called as crust beta, and due to that the female will emit a lot of foul smell. We know cause of this condition is a bacteria known as Klebsiella azene. इसीलिए atrophic rhinitis is also known as azena. So atrophic rhinitis is caused by a bacteria known as Klebsiella azene. Therefore this condition is also known as azena beta. Important is in patients of atrophic rhinitis, if they ask you what is the treatment of choice, so treatment of choice in patients of atrophic rhinitis, I hope all of you are quite aware. What is the treatment of choice in atrophic rhinitis? The treatment of choice in atrophic rhinitis, answer has to be very good. The treatment of choice is not a surgery initially. We don't go for a surgery in every patient. We will always try for a alkaline nasal douching first. Every morning we have to make a alkaline solution, and we have to wash our nasal cavities or wash our nostrils beta with this alkaline solution, so that all the crust which has formed beta, that will get cleared. Clear about the alkaline nasal douching has to be definitely beta the treatment of choice in patients of atrophic rhinitis. Okay, so alkaline nasal douching is the treatment of choice. If it fails, then surgery of choice. If they ask you, then it is modified Young's operation. So don't mark modified Young's as the treatment of choice. I'm warning you again. Treatment of choice is alkaline nasal douching. If that fails, then we go for the treatment, and that is modified Young's operation. Modified Young's operation means closing both the nostrils beta partially. So partial permanent closure of both the nostrils beta, that is what is called as the modified Young's operations beta. Clear about? Chalo. Next important is question number 37. It states beta a person complains of hearing loss bache along with the pure tone audiometry beta reveals a poor bone conduction and air conduction. I hope all of you are quite aware. Let me know in the chat box that whenever there is a poor air conduction as well as a poor bone conduction, that is suggestive of which type of hearing loss? Conductive hearing loss or a sensory neural hearing loss, CHL or SNHL. He gives history of beta of a hospital admission few weeks ago bache in view of meningitis. The patient is actually suffering from a post meningitis hearing loss or a post meningitis deafness beta, right? You suspect the spread of infection bache to the inner ear via which among the following routes they are asking you. So I hope beta, very good. When they say that the patient is having a poor bone conduction and a poor air conduction, that means it is a case of SNHL or a sensory neural hearing loss. Important is sensory neural hearing loss can happen either due to damage of cochlea or due to damage of the 8th cranial nerve. Why this patient is actually having a post-meningitis deafness? I hope all of you are quite aware that there are two fluids inside the inner ear. One fluid is known as endolymph. We know better that endolymph is produced by a stria vascularis. Endolymph is produced by the stria vascularis beta, and it is absorbed by the endolymphatic sac. But the another fluid which is present is called as perilymph. We know perilymph is nothing else but CSF, yes? So whenever it is inside the subarachnoid space, it is called as CSF or cerebrospinal fluid. But whenever it is coming into the inner ear beta, whenever the CSF comes into the inner ear, then it is basically called as perilymph. Now via which route basically beta? Via which route definitely the CSF comes into the inner ear? Via which route the CSF comes into the inner ear? Let me know in the chat box. Via which route the CSF comes into the inner ear beta and forms the perilymph? CSF comes inside the inner ear. Which among the following routes? Options which are given. We know that CSF, very good. It comes into the inner ear beta via aqueduct of cochlea. Okay, via aqueduct of cochlea. So in case beta, if the CSF can come from the subarachnoid space into the inner ear beta, we know even an infection can come by this aqueduct of cochlea beta along with CSF. Okay? So whenever a person was having meningitis, now what has happened, that bacteria or that organism might have come down into the inner ear beta via the aqueduct of cochlea, and that is the reason why the patient is actually having this post meningitis deafness. So answer to this question has to be option A, that cochlear aqueduct or the aqueduct of cochlea is the route of spread beta for the infection, okay, leading to post meningitis deafness. Endolymphatic sac is going to be responsible for absorption of endolymph beta. Vestibular aqueduct is a connection not between the cochlea, it is a connection between the cochlea and subarachnoid. It is a connection between the vestibule and the subarachnoid space. Fissure of Santorini is actually a opening beta in the floor of the external auditory canal. We know external auditory canal has some natural defects like the fissures of Santorini in the cartilaginous part and the foramen of Hutschke in the bony part. Via fissure of Santorini or foramen of Hutschke beta, the infection of external ear, that is otitis externa, will spread to the parotid gland, leading to parotitis. So after an external ear infection, when the patient will develop parotitis, then answer the route of spread is either as fissure of Santorini or foramen of Hutschke. Clear? यहाँ पे देख सकते हो, this is nothing else but beta your cochlea. Okay, this is nothing else but बच्चे your uterine saccule that is present inside this bony covering known as vestibule. ठीक है, and these are your semicircular canals. There will be three obviously. ठीक है, याद रखना है बात. Important is this is the endolymphatic sac beta which is actually going to drain the endolymph बच्चे. That is what is important to remember. Clear? And this is the aqueduct of cochlea beta which is the connection between subarachnoid space and inner ear. Okay, via this the CSF comes down into the inner ear forming the perilymph beta. And this is the space from which the infection can also spread beta. Okay, clear? Question number 38 now. Here they are asking you beta which among the following statements are correct about the hair cells of organ of Corti. Now let's talk about them one by one beta. Just go through this picture once. The table. We know beta in the cochlea there are definitely three parts. Okay, the middle part which is formed by the membranous cochlea is called as scala media. The lower part in connection with the middle ear is called as scala tympani, and the upper part in connection with the uterine saccule is called as scala vestibuli. Important is in the scala media beta, we know definitely we will have the basilar membrane and we have the Reisner's membrane, and on the basilar membrane beta we have the sensory end organ of cochlea, and that sensory end organ of cochlea is nothing else but organ of Corti beta. That is important. Ab यहाँ पे you can see this is the basilar membrane on which you are having this organ of Corti beta. Organ of Corti is going to have two types of cells, we know beta. One is mainly the inner hair cells बच्चे, and second are going to be the outer hair cells of cochlea. So one are the inner hair cells and second are the outer hair cells of cochlea beta. Both of them have different function, and these hair cells are covered by a tectorial membrane beta. These hair cells are covered by tectorial membrane. Now whenever the vibrations will come inside beta the cochlea, okay, the basilar membrane is going to vibrate. Due to that the inner and outer hair cells are going to vibrate. Whenever the topmost hair cell vibrates and it hits the tectorial membrane, the sodium channels are going to open up. As the sodium channels will open up in the cell beta, that will lead to sodium influx leading to depolarization, or there will be generation of action potential. Then that action potential or then that electrical impulse will be carried further beta by the 8th cranial nerve or the auditory pathway. Okay, so that is important. That is how the physiology is there. Important beta, yaad rakhna. These are all the other types of cells beta. These are four types of minor cells. What are the four minor cells that are present? One is the cells of Hansen. Okay, one are the cells of Hansen beta. Second are the cells of Claudius. third are the cells of Bocho, and fourth are the cells of Dieter's beta. These are the 4 types of cells. Yaad rakhna, they may ask you just a one liner. These type of cells will be present in, the answer has to be organ of Corti or inside the cochlea. Clear? Just remember the names of these cells. These are minor cells. Now the major 2 cells which are there beta, we know one is going to be the inner hair cells and second are going to be the outer hair cells of cochlea. Now when I talk about the inner and outer hair cells of cochlea, understand the basic differences. First, we know that inner hair cells are always arranged only in a single row beta. Okay, so inner hair cells are only arranged in a single row beta. That is important to be remembered. But outer hair cells are going to be arranged in 3 parallel rows. Outer hair cells are always going to have 3 parallel rows. Next, inner hair cells are going to be round and small and straight beta, but the outer hair cells are going to be long and slim. The inner hair cells which are there, they are going to transduce the mechanical energy into neural signal. Matlab, what is the function of inner hair cells? They will convert the mechanical energy of vibrations into electrical energy of electrical impulses or action potential. Matlab, the main function which is there, converting of the mechanical energy of sound or vibrations into electrical energy. Why? Because your brain only understands electrical energy. Barabar? You have to convert the mechanical energy of vibrations into electrical energy. That transduction of sound is mainly done by inner hair cells. Outer hair cells क्या करते हैं? Okay, they actually appear to impact the sensitivity of cochlea beta. मतलब they actually just try to amplify that sound a bit beta. That is what is the function. They help the inner hair cells and they amplify the sound bache. Next important, if they ask you that inner hair cells, if they are damaged beta, patient will have a sensory neural hearing loss. If the inner hair cells are damaged, obviously the processing of sound is not going to happen, leading to SNHL or sensory neural hearing loss. Outer hair cells, if they are damaged beta, it will alter the properties of the cochlear input to the brain. Okay? Obviously, if the outer hair cells are damaged beta, definitely the cochlear input beta, it will not go up to the brain. That is going to happen. If they say beta, inner hair cells are only 3000 to 3500 in number, outer hair cells are almost 3 times the number. Matlab almost 9000 to 12000 beta. Hopefully clear. Ab yahan pe let's see which among the following statements beta they are correct. They are asking you which among the following statements are correct beta about the hair cells of organ of Corti. So about the hair cells of organ of Corti, if they ask you, option A says beta there is 1 row of inner hair cells and 3 rows of outer hair cells. Is it true? Yes, we know beta there is 1 row of inner hair cells and 3 rows of outer hair cells beta. Option 2 says inner hair cells are responsible for transmitting the auditory impulses. Is it true? Yes, we know beta that inner hair cells are responsible for transducing and transmitting the auditory impulses. Option 3 says majority of the afferent fibers which are there beta. Majority of the afferent fibers which is there of the spiral ganglion supply the inner hair cells. Yes beta, that is also true statement that majority of the afferent fibers of the spiral ganglion which are there beta, they are going to supply the inner hair cells. That is important. Outer hair cells primarily initiate the electrical signals sent to the brain beta. No, please remember, okay, it will not primarily initiate beta the electrical signals sent to the brain in response to sound vibrations. Initiation which is there beta, initiation which is done, it is done by the inner hair cells, not by the outer hair cells. ठीक है, पहला जो काम होता है to convert the vibrations into the electrical signals or electrical impulses is not done by outer hair cells, it is done by inner hair cells. Outer hair cells will help in the process, but main function is done by inner hair cells. So obviously option 4 is going to be false beta. So statement 4 is false. So 1, 2 and 3 are the correct statements beta. So 1, 2 and 3 are correct statement. Answer has to be option A. 1, 2 and 3 are the correct statements beta. Answer has to be option A. Clear hai baat? Question number 39. 39 says beta a virus has special affinity bache for a stratified squamous non-keratinized epithelium. Which part of the patient's larynx is likely to get affected beta? We know this virus which has a special affinity to the stratified squamous non-keratinized epithelium is going to be which virus? Let me know in the chat box. What is this virus beta which has a special affinity to the stratified squamous epithelium? Anybody? Have a virus having special affinity towards the stratified squamous epithelium. We know, yes, stratified squamous non-keratinized epithelium, it is only present in one part of the airway beta, and that is option B, that is vocal cords or the glottis. So these are the affected side, that's fine. Supraglottis is a part of larynx which is lined by pseudo-stratified ciliated columnar epithelium. Bronchus and trachea are also a part of the airway, so they are also lined by pseudo-stratified ciliated columnar epithelium. Vocal cords are the only ones beta that are usually having the stratified squamous epithelium. Yes, and that's the reason why the patient will have a HPV infection. That was a recent NEET PG question beta, yaad rakhna baat. HPV has a special affinity towards the stratified squamous epithelium. That's the reason human papilloma virus infection you will always find in sites which have stratified squamous epithelium like oral cavity, anal canal, cervix, or the genital areas beta, or even the larynx, that is a vocal cord. Clear? And we know beta HPV 6 and 11 are responsible for causing this infection, not 16 and 18. 16 and 18 are associated with cancer. 6 and 18 is associated with laryngeal warts basically. And these laryngeal warts beta, which are seen over the free surface of the vocal cord, they are also called as laryngeal papillomas. So it is a case of a laryngeal papillomatosis or a laryngeal wart beta. Important is, yaad rakhna, laryngeal papilloma happens due to HPV 6 and 11 beta. And important is, what is the source? We know the source is mother having genital warts during delivery. Matlab, the child was born by a normal vaginal delivery and the mother was having laryngeal warts. The mother was having genital warts at that time. From there, the child acquired beta this virus infection, virus basically. The child will develop this laryngeal papillomas or laryngeal warts by around school age, that is 4 to 6 years of age, and the child will come to you with main complaint of hoarseness of voice. As the vocal cords are damaged in the patient, the child's main complaint is going to be hoarseness of voice, and second will be stridor. Respiratory distress is very uncommon beta in this patient. Take it, the hoarseness of voice and stridor will be the main complaint. In case if respiratory distress is present, what will be the airway of choice? Tracheostomy or a endotracheal intubation? If definitely beta you are suspecting a respiratory distress beta in patients of laryngeal papillomas, what is going to be beta the airway of choice? Endotracheal intubation or tracheostomy? If they ask you beta treatment, हमें पता है treatment has to be nothing else but CO2 laser excision. You have to use a CO2 laser and excise all these warts beta or all these overgrowths from here. ठीक है, तो CO2 laser excision has to be the treatment in patients of laryngeal papilloma. Very good. Tracheostomy has to be the airway of choice. Reason, endotracheal intubation is usually avoided in patients of laryngeal papillomatosis. Reason is that endotracheal tube may come in contact with the warts and it will take the virus down into the airway of the patient that we don't want. इसीलिए endotracheal intubation should be avoided. Next is a case beta, a patient of head injury following a road traffic accident beta or RTA was brought to the hospital. He was conscious, having a clear watery nasal discharge. We know clear watery nasal discharge beta could be a mucus or it could be CSF beta. Okay, after head injury, it is more chances that the patient is having a CSF discharge. Okay, through the right nostril. NCCT head was done, which reveals a non-operable injury beta on the frontobasal area. Okay, there is a non-operable injury on the frontobasal area. Which among the following is the best investigation to confirm the diagnosis of the patient? So we know that whenever the person is having a clear watery nasal discharge after an injury beta, it could be a case of a CSF rhinorrhea, whenever the CSF leaks out by the patient's nose. It could be a diagnosis of CSF rhinorrhea. Now, we know the most common cause of CSF rhinorrhea is trauma itself beta, and there will be damage at the cribriform plate. So whenever there is a cribriform plate ka fracture, patient has a CSF rhinorrhea. It could be seen in anterior cranial fossa fractures or La Forte fracture type 2 and 3. Patient may also have malignancy or infections which can cause CSF rhinorrhea. Whenever the person comes to us, the first step is ask the patient to sniff back the discharge. If the patient is not able to sniff back the discharge, if the person is not able to sniff back the discharge, it is surely CSF. Second, do a handkerchief test. Handkerchief test pe beta, when you take the sample, okay, you will wait for some time, you will see that the discharge is non-sticky beta. If the discharge is CSF beta, not mucus, then we see that the discharge is non-sticky and the handkerchief will not turn stiff beta after some time. If it was mucus, the handkerchief would turn stiff beta, kadak ho jayega. But if it is CSF, it will not turn stiff. Reason, CSF is like water. Next important beta, I can do a HRCT skull base. HRCT or high resolution skull base will actually help me to identify site of leak beta. Okay, so site of leak find out karne ke liye the best radiological investigation is HRCT skull base. If HRCT skull base is not able to give me a site of leak, then I should go for CT cysternography. CT cysternography is also done better to find the site of leak, but the only problem is it is invasive. So only if HRCT skull base fails, then we go for a CT cysternography beta. And we know the best investigation or the gold standard investigation to diagnose the case of CSF rhinorrhea is beta to transferrin estimation. If that sample contains beta to transferrin, that means it is surely CSF, nothing else. The best investigation to confirm the diagnosis beta has to be nothing else but beta to transferrin estimation. Clear about answer has to be option D. We know if it is a case of a bloody CSF rhinorrhea, matlab whenever a patient will have trauma and there will be a bloody CSF coming out of the nose beta, to check whether it is only blood or CSF mix, then we have to take a blotting paper and take the sample on that blotting paper. You will see that the blood and CSF will start separating, leading to multiple rings called as the target sign or the double target sign. So you are able to find a target or a double target sign beta. Along with that, you are able to see a halo. The halo is the CSF surrounding the blood. So double target sign, that was a recent question, or a halo sign is going to be seen on the blotting paper beta. There is no handkerchief sign, there is handkerchief test that we do. No sign, that was the option that people got confused with. Treatment for CSF rhinorrhea beta, we know majority cases of CSF rhinorrhea are only treated by conservative management. So for 7 to 14 days beta, the patient will be kept on conservative management, where we will try to actually control the ICP of the patient. We will just try to decrease ICP of the patient by advising bed rest or giving mannitol, so that the CSF leakage or the CSF rhinuria decreases. Even after 7 to 14 days beta, if the patient's condition doesn't improve, matlab if conservative management fails, then we go for a surgical repair. And only those conditions we go for a surgical repair. Antibiotics are also given to prevent meningitis only. Next is a quiz beta where they are saying, very classical and sarkari question. A neonate was brought to you beta with a neonate was brought to you by the parents which a neonate was brought to you by the parents beta with complaints of stridor since first week of life. So from the first week of life, the baby is having stridor beta. On examination, stridor increases whenever the child cries or whenever the child lies in supine position. Why? Because whenever the child cries beta or lies in supine position, the airway of the child will get actually more obstructed, and that's the reason the stridor increases. But the stridor decreases in prone position. Reason? In prone position beta, the epiglottis falls back and therefore the stridor is decreasing. What will be the examination finding that will be observed in the child beta? What will be the examination finding observed in the child? Please let me know what is going to be the provisional diagnosis of this case. The provisional diagnosis in this case is a neonate has been brought to you beta with a stridor, that too from first week of life, and it increases in supine position and decreases in prone position. Classical diagnosis of laryngomalacia. Very good. It is a classical diagnosis of laryngomalacia. We know malacia means softness or weakness. So whenever a person is going to have a laryngomalacia beta, what is going to happen? The larynx of the patient or the supraglottis of the patient is extremely soft or weak. And if the supraglottis is weak, even the epiglottis is weak beta. And if that epiglottis is weak, the epiglottis is going to fall down. And if that epiglottis is weak or loose, that loose epiglottis or that floppy epiglottis falls down beta. And whenever that floppy epiglottis falls down, it is going to block the airway beta, causing obstruction of the airway, leading to an inspiratory stridor. So yaad rakhna, this was a question that which type of stridor is found in laryngomalacia. We know the type of stridor seen in laryngomalacia will be an inspiratory stridor beta in the child. That is what is important. Yeah, the inspiratory stridor will be seen. Now, whenever the child lies in supine position, the epiglottis closes the larynx more, leading to worsening of the stridor. But whenever the child lies in prone position, the epiglottis falls back, opening up the larynx, and therefore the stridor decreases. Yeah, we know this is the classical case beta where on a laryngoscopic examination, we are able to find a loose epiglottis or a floppy epiglottis. The answer has to be option D. And this floppy epiglottis, therefore, it will not appear leaf shape beta. This floppy epiglottis is going to appear like this. What is that shape called as classically? Omega shape beta. This floppy or the loose epiglottis is going to change the shape beta, and it is going to appear like omega shape. There's an omega shaped epiglottis which will be found. So either a floppy epiglottis or omega shaped epiglottis beta is going to be found in the patient who is having laryngomalacia. Clear about that? Is important to remember. We know turban epiglottis or a mouse nibbled appearance of vocal cord. Both of them are features of TB larynx. Whenever a patient will have tuberculosis of larynx, these will be the features. Keyhole glottis is a feature of phonesthenia. We know whenever a patient will have phonesthenia beta, that is whenever the adductor muscles of vocal cord will be weak. The adductor muscles will not be able to close the vocal cord completely, leading to a keyhole appearance of the vocal cord beta. Okay, so keyhole glottis will be seen in phonesthenia, wherever the adductor muscles are weak. In this patient will have a weak or a breathy voice. Okay? Here you are able to see this is the normal epiglottis. Here you are able to see a red or a swollen epiglottis beta with these yellow spots on it. Red swollen epiglottis with yellow spots on the surface is known as a turban epiglottis beta. This is the classical picture of turban epiglottis. Next, this is the appearance of vocal cord which appears to be as if it has been eaten by the mouse beta. This is called as the mouse nibbled vocal cord. So if I am able to see a turban epiglottis along with mouse nibbled appearance of vocal cord, both of these are classical features of nothing else but tuberculosis of larynx. We know that tuberculosis of larynx caused by Mycobacterium TB beta, it is not a primary infection, it is always a secondary infection. Matlab, patient would have a pulmonary TB beta and from there the infection will spread to the larynx. So TB larynx is always a secondary infection. Second, it is always painful. All other types of TB can be painless, but TB larynx is always painful, extremely painful. Okay? Initially it will cause redness of the epiglottis, but later on it will lead to turban epiglottis. And in the last stages, the vocal cords will get completely damaged, called as mouse nibbled appearance of vocal cord. And we know TB larynx with the treatment is nothing else but ATT, that is a antitubercular therapy. Question number 42 beta. It states that identify the correct statement which is regarding the below given investigation. What is the below given investigation? Identify please. What is the below given investigation that you are able to see? The below given investigation that is there beta. What is this? Here you can see applied, we have applied electrodes beta over the patient's head or the brainstem area, and we are going to record the electrical activity from the patient's auditory pathway or the brainstem area. This is nothing else but a case of BERA. This picture is of BERA, OE ऐसा नहीं होता. Why you will apply electrodes over the head in autoacoustic emission? So it is a BERA beta, that is a brainstem evoked response audiometry. Clear? Autoacoustic emission is this, when no electrodes will be there. Autoacoustic emission is what we know beta. Here we will give sounds to the ear of the patient, and then we will record the echoes coming from the outer hair cells of cochlea. If echoes are noted, if echoes are detected from the outer hair cells of cochlea, matlab the patient's cochlea is normal. So can I say that autoacoustic emissions can actually help us in routine screening of hearing in neonates? Matlab whenever every neonate is born beta, so if you have to check whether the patient's hearing is normal or not, so to check the hearing of the patient beta, you can definitely use autoacoustic emission. So routine screening of hearing in neonates beta can definitely be done by the autoacoustic emission. That is what is important to be remembered. No issues with this, anybody? So yaad rakhna, this was a PYQ. Routine screening of hearing of neonates is done by autoacoustic emissions beta. Except in high risk patients, that is meningitis babies or NICU babies, in those patients we may need a BERA beta. Okay? Whereas if I talk about beta, autoacoustic emission is more portable, it is much cheaper. BERA is definitely more expensive and not easily available everywhere. BERA mein, here we will give sounds to the ear of the baby, and then we will definitely record the electrical activity from his auditory pathway or the brainstem area. Okay? And in this condition, again, patient's participation is not required. So both these tests are objective in nature. And important is, whenever you record the electrical activity from the auditory pathway, that means you know the patient's hearing is absolutely normal. Now important is, there are total 7 waves in the graph of BERA beta. Most important wave is wave number 5. Let me know in the chat box. Wave number 5 is usually generated from which part of the auditory pathway? Wave number 5 is generated from which part of the auditory pathway? We know beta, the wave number 5 is the most important and the largest wave of BERA, and this most important or the largest wave of BERA is usually generated from, very good, lateral lemniscus. So lateral lemniscus is the part beta of the auditory pathway jahan se the wave number 5 is going to originate. Clear? Now if they ask you that which among the following is the correct statement about BERA beta, option A says it is used for routine screening of hearing in neonates. Is it true? No beta. Routine screening of hearing is in neonates beta is done by OAE, that is autoacoustic emission. BERA is expensive. It is only used in few cases like meningitis vagara. Largest wave generated beta is from the medial geniculate body. No beta. We know the largest wave generated in BERA is the 5th wave, and that is from the lateral lemniscus, not from the medial geniculate body. Option C says it records the echoes bache from the outer hair cells of cochlea. Absolutely not. Reason beta, we know that it records the electrical activity from the auditory pathway in the brainstem area. Okay, or the recording of echoes from the outer hair cells of cochlea is done by autoacoustic emission beta. It is used for hearing assessment in meningitis babies. Yes, absolutely a true statement beta. We know answer has to be option D, because it is used in hearing assessment in patients of meningitis or in NICU babies beta. Okay, in those conditions it has to be used. Answer has to be option D. Clear? Chalo. Next important question number 43. If they ask you, they are asking you mark the incorrect statement beta regarding the condition that has been shown in the below given CT image. So if they ask you about the incorrect statement about the regarding condition, so pehle we have to understand the condition which has been given in the CT beta. Please tell me, what is this condition, anybody? What is this condition, anybody? Bolo, what is seen? Here you are able to see beta, the whole maxillary sinus of the patient which is there beta, it appears whitish. We know normally the maxillary sinus should not appear white because it is filled with air. Here it is appearing whitish. Reasons can be two of them. First, either it can have beta a lot of mucus collected inside it, like a mucocele can develop due to sinusitis, or it could be a case of a maxillary sinus carcinoma. What is it? Is it a case of a maxillary sinus carcinoma, or is it a case basically beta about a maxillary sinusitis? What do you think? Is it a maxillary sinus carcinoma, or is it a case of maxillary sinusitis causing mucocele? Anybody? So please remember beta, here, no, it is not a maxillary sinus carcinoma bache. Please remember that it is maxillary sinus carcinoma hota to bone would have been eroded. Here you cannot see that any bone is eroded. If there is no bone erosion beta, it is not a case of a maxillary sinus cancer. Yes, it is a case of maxillary sinusitis beta, which might have led to this complication bache. Now this complication can be either two of it. We know one, it can be mucocele formation, but we know mucocele is less common in maxillary sinus. Mucocele commonly forms in the frontal sinus beta. Next important is an aspergilloma. We know that whenever the patient will have a fungal sinusitis due to aspergillus, it is more commonly in the maxillary sinus, and that can lead to a complication known as aspergilloma beta. So it more commonly seems to be a case of aspergilloma bache due to maxillary sinusitis. Barabar? Aspergilloma seems to be a more likely presentation. Option A says it is associated with nasal polyps. We know beta, yes, aspergillus infection is usually associated with bronchial asthma or any of the allergic conditions. So it can be associated with nasal polyp beta. Serum IgE levels are elevated. Yes, I have told you it is associated with bronchial asthma or allergic conditions. So even the serum IgE levels can be elevated. It leads to erosion of bone. No, it is not a case of a maxillary sinus cancer. So it cannot cause any erosion of bone beta. It is caused by aspergillus species. Yes, we know aspergilloma is always caused by aspergillus species. The answer has to be option C beta. Option C is that incorrect statement beta, which does not fit over here. Clear? You could have seen aspergillus, IgE, nasal polyps. All of them are related somewhere to the allergic condition. So you should have definitely thought about beta that which one is the odd one out. Okay? So sometimes you have to just find the odd one out and mark the answer. Clear? So that is important. We know whenever a person is going to have sinusitis beta, we know the patient will come to us with complaints of headache, nasal discharge, a post-nasal drip. Okay? These kind of features. Now for sinusitis beta, we know first line investigation is always the X-ray PNS, that is the X-ray paranasal sinuses, where various views can be taken. The best radiological investigation beta will be a NCCT paranasal sinus. Anybody, when do you suspect that the patient is having sinusitis on an X-ray or a NCCT paranasal sinus? What should be the feature that should be seen on the X-ray or the NCCT paranasal sinus to diagnose it as a case of sinusitis? Let me know in the chat box. What is the feature that you should observe? What is the feature that should be observed beta on the X-ray or the CT paranasal sinus to call it as a case of sinusitis? Follow. To call it as a case of sinusitis beta, what should be observed? Anybody? I've discussed this. What should you observe classically? We know जब भी sinusitis होता है, we know the sinus, the metastasis of the patient are blocked. Due to that, the sinuses are not able to drain the secretion, and that causes sinusitis. And due to sinusitis, definitely beta, we know the patient will have infection or pus collection inside the sinuses, and that will give you the classical feature. कितनी बार बोला है, let air fluid levels will be seen. The pus will deposit in the lower part of the sinuses, giving us the classical air fluid levels. So air fluid levels, if they are seen on the X-ray or NCCT paranasal sinuses, that is going to be definitely a feature of sinusitis. याद रखना है बात. In cases of aspergilloma, mucocele, cancers, air fluid levels are not seen. Whole sinus appears white. Clear है बात? The air fluid levels are a feature. Important. What is the gold standard investigation to confirm the diagnosis of sinusitis? What is the gold standard investigation in sinusitis? Anybody? What is the overall gold standard investigation in sinusitis? Let me know. We know that sinusitis commonly happens due to bacterial infections beta, like streptococcus pneumoniae is the commonest cause. So treatment, we know it is oral antibiotics should be given beta for a span of 3 weeks along with nasal decongestants. Oral antibiotics for 3 weeks along with nasal decongestants has to be given beta. Okay? But if that fails, then you have to go for surgery. That is a FES surgery known as functional endoscopic sinus surgery. If that fails, you have to go for FES surgery, that is functional endoscopic sinus surgery. Yes, very good. It is nothing else but sinus puncture and a pus culture beta. So we have to puncture the sinus and we have to take the pus and send it for culture. So pus culture is going to be the gold standard investigation. If that is not an option, then mark it as nasal endoscopy. Okay? Pus culture is always the gold standard investigation, not an option. Go for nasal endoscopy as the second best. Clear? Now if they ask you about the X-ray paranasal sinus, various views beta. The first view, here it appears as if the patient is looking upwards and drinking water. So this is nothing else but Waters view beta. And here the patient's mouth is open. So this is nothing else but a Waters view beta with the open mouth. Waters view with open mouth is known as, anybody? Let me know in the chat box. Waters view with open mouth will be called as, this is a Waters view, also called as the occipitomental view. What is the more specific name? Yes, the more specific name for this open mouth Waters view beta is called as the Pierce view. We know the more specific name for this open mouth Waters view is known as the Pierce view. Now we know on Waters view or Pierce view beta, all the sinuses are visible except which sinus is never visible. Which sinus is never visible on the Waters view or the Pierce view? Let me know in the chat box. Which sinus is never visible? We know it is the best view beta for the maxillary sinus. For maxillary sinus, it is going to be the best view basically. याद रखना ये बात. Important. All the sinuses are visible beta except sphenoid sinus is also visible on a Pierce view when the person opens the mouth. Sphenoid sinus is also visible. Only sinus that is never visible basically beta on a water's view or a Pierce view. Answer has to be posterior ethmoidal air cells. Yes. So posterior ethmoidal air cells is never visible basically beta on a water's view or a Pierce view. That is important to remember. Clear about? We know this is nothing else but X-ray skull lateral view beta. And I hope all of you are quite aware that X-ray skull lateral view is the best view for the sphenoid sinus. It is the best view for the sphenoid sinus beta. And do remember that X-ray skull lateral view is the only view of the paranasal sinuses where all the sinuses are always visible. So all the paranasal sinuses are visible only on the X-ray skull lateral view beta. That is important to remember. Clear about? Next important, if I talk about, this is the Caldwell's view beta. So this is the Caldwell's view basically, also called as the occipitofrontal view. So Caldwell's view or occipitofrontal view bache is going to be the best view for the frontal and ethmoidal sinus. Caldwell's or the occipitofrontal view is the best view for the frontal and the ethmoidal sinus beta. And this is the classical NCCT, and you can see that this NCCT is showing you, this is the pus collected over here, showing your fluid level, and this is the air. So this is the air fluid level that you are able to see on the NCCT PNS. It is suggestive of sinusitis in the patient beta. Yeah. Chalo. Question number 44. If they ask you, a patient has presented to you beta with a unilateral nasal obstruction associated, this has been a PYQ of FMGE exam. A patient has presented to you beta with a unilateral nasal obstruction associated with a watery nasal discharge beta. Associated with a watery nasal discharge. Okay. And the patient is also having bleeding. Below given examination finding is observed. Which among the following statement is true? Which among the following statement is true? Let me know in the chat box. Bolo. There was a unilateral nasal obstruction beta. We know what is the diagnosis of this case. What is the diagnosis? Very good. Here you are able to see a tumor arising from the lateral wall of the nose and it grows inwards beta. It grows inside. Therefore, it is called as an inverted papilloma, also known as a Ringer's tumor. So this is a picture of an inverted papilloma of Ringer's tumor beta. The inverted papilloma or Ringer's tumor is the diagnosis of the case. We know it arises from the lateral wall of the nose, common in adults beta. Treatment of this condition is nothing else but surgical excision beta. But if they ask you what is the true statement about this, so please remember beta, answer has to be. So please remember the answer has to be in this condition. Which one? Yes, so we know it is benign beta, but it is going to be invasive. I have told you 3 tumors in ENT which are benign but invasive. First, a juvenile nasopharyngeal angiofibroma. Second, inverted papilloma, also known as Ringer's tumor. And third, a glomus jugulare or glomus tympanica. These are the 3 tumors which are benign but they are invasive beta. Answer has to be option C. So benign and aggressive or benign and invasive has to be the answer for this question. Clear about this was a PYQ. Next important last question, question number 45 beta. Here they say a patient presents to you with painful vesicles beta. Okay, in the external auditory meatus. The patient is having painful vesicles in the external auditory meatus and also over the tympanic membrane beta. He also complains of drooling of saliva beta and there is pain in the facial and the temporoparietal region. Patient is having pain in the facial and the temporoparietal region beta. What is the likely diagnosis and site affected? Please tell me. We know beta, here what has happened, the patient was having the patient is actually now having a herpes zoster or varicella zoster infection. The patient would definitely have a herpes zoster infection in childhood beta, and that herpes zoster or that varicella zoster infection, okay, will cause chicken pox. But what has happened beta, that infection did not get completely eliminated from the patient's body. The varicella zoster virus did not get eliminated from the patient's body. It stayed inside the patient's body in a dormant state beta, okay, in a resting state. And whenever the patient became immunocompromised, especially in elderly age, okay, whenever the patient became immunocompromised beta in old age, this virus got reactivated. This virus gets a chance of reactivation. I have told you 3 sites beta. First, if that virus gets reactivated from the dorsal root ganglion, it causes painful vesicles in a specific dermatome of skin. Whenever it gets reactivated from the dorsal root ganglion, it causes painful vesicles in a specific dermatome of skin called as shingles. Next, whenever beta it gets reactivated from the trigeminal ganglion, patient will have painful vesicles in the ophthalmic and maxillary division of trigeminal nerve. So whenever a person will have painful vesicles in the ophthalmic and maxillary division of the trigeminal nerve, patient will have a condition known as herpes zoster ophthalmicus. The patient develops a condition known as herpes zoster ophthalmicus. And whenever there is reactivation of virus from the geniculate ganglion, geniculate is a ganglion of 7th cranial nerve, the facial nerve. So whenever the person will have reactivation of the herpes zoster virus or varicella zoster virus from the geniculate ganglion, patient will develop a condition known as herpes zoster oticus or the Ramsay-Hunt syndrome. Patient develops a condition known as herpes zoster oticus or the Ramsay-Hunt syndrome. The answer to this question has to be option C, Ramsay-Hunt syndrome. That is also known as herpes zoster oticus, and the virus has got reactivated from the geniculate ganglion. Clear about that is important beta. Why? Because the painful vesicles were seen in the external auditory meatus and over the tympanic membrane. So it is a case of herpes zoster oticus beta, not herpes zoster ophthalmicus. Clear about Melkerson-Rosenthal syndrome definitely is not due to reactivation of herpes zoster virus. Post-herpetic neuralgia is a severe pain which happens after herpes infection beta. Okay, but here there is reactivation of the virus. Okay, shingles and dorsal root ganglion, that would be a case beta when there will be painful vesicles in a specific dermatome of skin. Here the painful vesicles beta in the patient's ear, and we know the patient is having drooping of the mouth on the affected side. Why? Because we know the patient will have a lower motor neuron 7th cranial nerve palsy beta, or a facial palsy. Most common cranial nerve palsy which is seen in Ramsay-Hunt syndrome is the lower motor neuron facial nerve palsy beta. That was a PYQ again in your exam. Treatment, we know the drug of choice in this condition has to be acyclovir again, but we know in this condition it is not topical. Here it is a oral acyclovir that is given, and that too at very high doses beta. Almost how much? 800 mg 5 times a day. So oral acyclovir for almost 800 mg 5 times a day beta has to be given in the treatment of Ramsay-Hunt syndrome or herpes zoster oticus. That was all about your ENT. Thank you so much. Take care.